Uh, Welcome everybody to the board meeting. First of all, welcome also to Iffy, who doesn't look like it, but actually is on the sick bed at the moment. So thank you very much for joining us, Iffy, and do bow out if at any stage you need to. We've also, I think, got Sophie coming online, and Nina is coming but is stuck in traffic, and so will join us as we can. And I think that's all of the apologies that we have. I also want to welcome some guests today. So Bailey, welcome. Bailey Mitchell's from Elft and is joining us as part of his shadowing different committees, and be very interested to get feedback at the end as well on anything that you see and you observe. And I also welcome Hugh and Chris here, who are from the Shadow User and Carers Committee and will be presenting. Have people, so we have observers as well who are free to make themselves known or not as they wish. I think this meeting will be being broadcast live. So I do need to remind people that we are still in the election period, and so please refrain from, not that I think you would be particularly tempted, but please refrain from any political comments or discussions. I think there are no other introductions or anything else, unless anybody's got anything else to say. So can we go, please, then to the minutes of the previous meeting? It's not my habit to go through these page by page. Can I just, I've sent in some comments, some corrections, relatively minor corrections around various things. Has anybody else got any they wish to raise? I think mine are probably non-controversial and are best dealt with just by mode. Okay, in that case, we will accept the minutes. We'll approve the minutes as read. There is one matter arising, and that's to receive an update on the co-occurring mental health, drugs and alcohol work across the trust, and we're receiving this through the Quality Committee, who received a report. Yeah.
We did have a very interesting presentation at the Quality Committee from the Comrade lead, and we recognised that it was connected to board conversation, but not quite as clearly as it needing to be something that came back to board. So I'd welcome some guidance from members of the board whether they want to see more than was included in the information from the committee this time round.
Thank you. Thoughts around the table? I was able to attend that, so I've seen that. Do people wish to see more than they've got at the moment, or are we content that Quality has seen it and looked at it in detail? I'm getting the impression we're content with what we got. Thank you. Okay. Yes, certainly, Jo.
At one point from the minutes, which is item 9. Which was the discussion we had about the issue of transgender people in prison, which in Helpfully Said was being picked up sort of in the kind of London way. I just wondered, it would be good at some point, and that may well be through Quality, but just to make sure that we are assured that that's not lost and it will come back directly or indirectly.
Thank you. Ian?
Yeah, I mean, I think the issue that we were talking about was how we kind of meet the needs of the transgender population in prisons, particularly transgender women in a female prison. And of course, we only operate in one female prison at the moment, which is in Kent. So I think when we were having that conversation previously, I said, because of the context in London where we are being asked to collaborate a bit more, I would certainly kind of take that back as a theme for us to discuss as a group. That meeting hasn't happened as yet. And what I will do with regard to East Sutton Park, which is the female prison in Kent, that is a conversation that myself and the regional service manager will have with commissioners and the governor, if that's okay.
So I think I'm hearing that these conversations are still ongoing, but it would be good to perhaps bring it back. So
I did think it could possibly be a topic for a board away day. So maybe we could build that up into more of a discussion to consider some of the issues.
I think that might be quite useful, because actually the issues that we're dealing with here are not only practical, but are also political and psychological, social. So I think it would be good perhaps if we could have the breadth of the board looking at this as well. So I think that would be good. Jo, you're looking concerned.
Yeah, I guess if the matter is only confined to Sutton Park, then I'm quite happy for it to be. I'm not sure it needs that breadth of discussion. I don't know if there's broader concerns across other services, then perhaps it does need that. If we're really just worried about, and I think the points you made, Suzanne, were not just the rights of the transgender individual, but protection for the other prisoners at East Sutton Park who typically are quite vulnerable. So, as I said, if we think this is and I'll be guided by Ian's view on this and other directors, if we think this is a Sutton Park issue, it's going to be a very specific issue in relation to people who happen to be going into that prison, then I'm quite happy that I don't think that needs the broader discussion, because it needs to be handled appropriately for whatever the situation is. If we think we want to talk more widely across services about these issues, then I think perhaps that is more for a board away day.
I think that's a really helpful way to divide the issue. My guess is if it's just about Sutton Park, probably we'll deal with it through committee. But so I think the substantial question to the board is, do we want to have a wider discussion around transgender and the impact on our services and how we support people, all the people involved in this, in the best way possible? Yeah.
Of course, through the kind of Building Fairer Oxleas services work stream, we do have somewhere where we can route this conversation. I mean, the kind of context that services are operating in terms of kind of meeting the needs of people who identify as transgender, there is a kind of framework for that, which we apply across all of our inpatient services. But it's something that we can review through that. And I would suggest, as we firm up our kind of reporting arrangements for BAFOS through the quality committee, we could kind of think about it through that route, and if necessary, then contemplate whether we need a kind of fuller board strategic discussion. Does that sound okay?
So people are happy with that route. I think what I think would be good is whether we have a fuller board discussion around that. I'm happy for this group to that route to decide it. I think at some stage as a board we probably need a briefing about it, because the non-execs in a way need to know and understand what our line is on this, because we are often going to be seeing people from outside the trust and we won't be as familiar with these discussions as other people. So I think it'd be good if we were at least briefed about it and the thinking behind whatever decision is made. I think that would help us when in our external facing roles, even if we don't need that discussion. Steve?
Yeah, just to echo that, the immediate problem is Sutton Park. That's where it's going to be felt quickest. Well, it already is being felt there, and it affects 4 patients, I believe, at the moment, 3 or 4. But it will be broader, and so as you say, I think an update, a development day would probably be good as well, part of a development day, so that there's some discussion enabled. So I think that's a really good way to play it.
Thank you. Sally, happy. Thank you. Okay, thank you. Okay, we now move on to a presentation which I'm very much looking forward to, service user and care and involvement focus. Neil, do you want to lead us into this?
Absolutely. Thanks, Chair. So We're way in now to quite an ambitious project of trying to bring lived experience perspective to the work of committees and to the board. I'll introduce Hugh in a minute, and I want to show a very brief film, but just to say something about the scale of the challenge that this is. To our knowledge, this hasn't been attempted anywhere else in the country. And I think it's worth just taking note of what we're trying to do. So the information we have at committee and board level is abstracted and it's dispassionate, and it needs to move at a certain speed to be effective. And lived experience, by contrast, is very specific to the individual and actually quite emotionally charged. So bringing those two things together requires patience and understanding and a lot of learning on both sides. I mean, certainly within the committee, a great deal of our time has been spent just trying to understand the organisation as a context. And I'm very grateful, particularly Sue and Sally coming along, explaining the organisation, which when you hear it, you think, goodness, well, I think I understand it now, you know. But it's really important that we do this because we close a circle. You could think of this as a validity check, really, that the data that we look at here comes from services. It's abstracted. We look at it in context of other services. And as a final check, we recheck it with the people who use our services. And that, I think, is very worthwhile. We have a standing joke in our group, which is, as I say, this has never been undertaken anywhere. And at this moment, we can completely understand why, because it is not without challenges. But I'm just going to briefly play a film, and then I'm going to introduce Hugh, who will talk about his experience, and happy to sort of take questions and sort of pose questions as well. But this film is really just to give you a sense of what the learning has been like within that, within the shadow committee.
I'm a carer for my mum and my brother. My brother has serious long-term mental health issues, and I'm also part of the shadow committee. As a carer, I've been a carer for over 20 years, and I've noticed that unless you've actually experienced what the service user is going through or the carer is going through, you can't honestly do justice to providing good care. So I thought that this is one way to change or help change the system within the Oxleas. So my main reason is to make improvements in the care for my brother and for everyone else.
Hi, I'm Patricia. I'm a service user. I'm a carer for my mum, who has lots of physical and mental health issues. I'm also part of the shadow committee. I think we have a unique set of individuals that have different experiences, different expertise, different cultural backgrounds, and it's a nice mix of people. In fact, I think now we've a nice community in ourselves. We've got people that are not afraid to challenge some particular views. It's been quite a nice group to work with, and everybody has good tolerance with each other. You know, you don't all go over each other all the time. We have respect for each other as well. That's very good.
I'm Marlena. I'm a member of the Shadow Committee in Common. I've joined it since last year, and I'm really honored to be a part of this organization. I think this is a really unique team because we have people from all sorts of backgrounds. We all have very different opinions and have very different upbringing maybe, and different approach to life or different lifestyle. This gives us an opportunity to really get to know all this diverse experience that everyone has. This, of course, it doesn't cover everyone in the UK, let alone the world, but hopefully we are getting closer to representing most people.
I think what made the impact better was that we had clear lines of communication with senior members of staff. We had their backing, and we could see that in fruition in actually looking at the different risk registers.
It's a very complex topic that needs an immense amount of time and effort to really discuss, and this committee has allowed us to have this really open discussion with each other, to be very vulnerable and just share all these sensitive informations that we have experienced with services. This is really important also because we are bringing service users and carers together with clinicians. We eliminate the problem of having miscommunications to bring in middle person to communicate with these different people, or using surveys and forms asking for opinions. We are bringing this to a more personal level, and we are learning a lot about how the system work. This not only reduce any doubts we have about the organization. We are learning a lot of positive informations about what the organization has done in terms of improvement efforts. This will also help us to bridge the gap between the knowledge from everyone involved. In turn, this hopefully will help us educate each other and share important solutions. We do come up with a lot of fresh opinions that sometimes have not really been talked about, and I think that's why it's quite important to have people who have lived experience, whether they are service users or carers, because sometimes a service may be approaching things based on research that's not quite unique and personal to a real life experience.
Dave, I may repeat some of the things that you've heard on the, I think, excellent videos. My son was diagnosed in 2006 with paranoid schizophrenia. So me and my wife has been looking after my son for the last 18 years using Bexley Mental Health Services, which was in Oxleas. Yeah. So I think we've got a good understanding of the services that we've received. And I'm a glass half empty, half full person, sorry. And obviously there's been lots of excellent experiences and some poorer experiences. I joined the involved group in February 2023. It was quite interesting to be involved in one or two projects regarding the mental health side, because obviously I'm very interested in that, and meeting the clinicians and explaining how we see it from the carer's point of view and the user's point of view. And it was quite interesting how we got great feedback by talking to them, just like I'm talking to you. It was very interesting how the positive feedback that we got. And then in August 2023, I was asked to join the Shadow Committee in Common. Now, obviously, we come with our own perceptions of the National Health Service, whether it's stuck in the 20th century, whether this might be a tick box exercise. So I was quite interested in being invited onto the Shadow Committee in Common. But we get excellent support from the staff that I've met, very professional, looking to be innovative and bring change to the organisation. And that really gave me a great boost to be part of that team. And there's lots of people that I'd like to thank for the help that we've given, too many to mention. I've got them written down here. It was Neil Joplin, there's Suzanne, Anne, Kelly, Asha. And the group is very diverse, not just in ethnicity, but in age, in experiences, in users. It's very diverse. And we've gelled into what I believe is a team, not just the Oxleas NHS and us as the Shadow Committee in Common. It's very much, we're all equals. That's what's transposed over the last 10 months. Yeah. Obviously, being involved in the risk registers has been very interesting, and we got excellent training and pointers from the group, from the NHS, and how the risk registers work, and what our role was, and how we could have our ideas put into the risk registers. And at the moment, we're doing the care plan, because obviously, as a carer, I believe that I should be more involved in the care plan, and it's nice that the management team that we've met are on the same line. The carer is obviously a key member of the care triangle, and it'll be interesting how the team here get that message down through the organisation by the clinical leads, when you try to get buy-in and get a critical mass to make these important changes. But there might be small changes, just small incremental changes can just be as good as Big Bang, I believe. And I'd just like to leave you with one question, really. How many of you have a lived experience or care for someone who does have that experience? And how do you bring this perspective to the board? And do you feel you're able to bring that perspective to the board? Any questions?
Thank you, Hugh. Questions or comments, and especially perhaps thinking as well about your question you posed us. Anyone?
Thanks, Hugh. I think we met at
Yes.
one of the events, so I think
Yes.
fellow engineer as well, so in good company.
That's correct.
Yes, the answer is yes. That's one of the reasons why I sort of applied to be a NED, because I'm a carer for my eldest son as well. So, and I hope that the other NEDs as well bring their experiences to bear on the group, and from my experience, we do. So, yeah, my answer to that question is yes.
Rachel.
Yeah, I think that's right. Actually, at the start of the last board, we all talked about why we're here.
Yes.
And I think that came through really clearly, and certainly in mental health and in the NHS, precisely because of those experiences and wanting to kind of make it the best sort of organisation that it can be. And I do think we draw on those experiences. That I think many boards perhaps are a bit more closed than that, but I do think those come out in these discussions, although I'm sure that there is scope for more. I think the committee is fantastic, and I'm already starting to see the richness of things that come out of it. One thing I wanted to reflect on is I think the skill set of us being leaders who engage with service users directly is something we could also really focus on getting better at as a group of leaders. I've watched Chaplin and Neil, and the way kind of setting the scene in a way which enables people to feel really safe about sharing their experiences, recognising that we're drawing out some things that will be very difficult for some people and how we can do that in the best possible way. So I'd be quite keen, I'd like to learn more about how to do that in the best possible way. And I just feel as though that's something, as we become an organisation that's more porous, that listens more and more, and really focuses on the experiences of people who use our services, I'd really like us to feel that we're a really skilled board as well at that sort of conversation, and I'd like to personally would like to get better at that.
Suzanne. Oh, sorry, Sophie. I apologise.
It's okay, I'm on a screen, so being hidden away. So thank you very much for that. I thought that was really, really interesting. Yeah, I have lived experience of using Oxleas mental health services, and I can comfortably say that I use that to inform what I say at board. And I think the reason I can do that is what Rachel has touched on, which is that psychological safety. It's how people behave, how discussions are had, and the respect people have for each other. And that's in marked contrast to other places where I've worked. So I think you have to feel safe. You have to feel safe before you do any of that. And I think, as Rachel said again, you can't rely on that to always be there. You have to constantly work to create that feeling of safety. So I think just wanted to say that's really, really important to me.
Thank you. Suzanne?
Thank you. And I just wanted to reflect a little on the experience that I had as a committee chair in terms of having the service user and carer committee redesign one of the risks. I think they did an absolutely brilliant piece of work. I think it's transformative, and the effects of it can be seen in the way in which the risk has been redefined. What it made me think very deeply about, as well as the value of hearing directly from our service users and recognizing that my experience of being a carer is unique to me, theirs is unique to them, but we need to bring in that diversity of experience. But what I was thinking about afterwards is that it really made me think and rethink how we conceptualize risk as an organization, because the way in which they saw the risk is the risk to the care that they get very directly. And it's very different from having a support network engagement tool and looking at the risk of that not having been completed. It really changed the way in which we're going to think about it. It made me think about how we use our risk register, particularly the BAF, for leverage in terms of organisational change and transformation. I think without necessarily recognising it, I think that what the service user and carer subcommittee has set us is a very profound transformational challenge for a mental health trust. I mean, I think all mental health trusts, in my experience, will pay lip service to the need to engage carers, and some will do it better than others. But I've also seen from serious incident investigations in the past in mental health that very often one of the real big risks for service users and for their carers, which can end up in service users taking their own lives, is not engaging sufficiently well with their support networks. So I think it's really critical from a safety point of view that they've raised that risk. The other thing, and I'd be very happy to share this experience with other committee chairs, is I think converting people's experience into organisational actions and making it a risk that a committee can monitor and pursue and push and hold people accountable for is quite a demanding process. I think it's intellectually demanding. I've really admired the group of people who came to talk to the Quality Committee and who engaged with me beforehand in terms of their the dialogue that we had in terms of trying to convert experience into an organisational system and a risk. So I thought it was a really exciting process, and I'm hoping that there'll be an opportunity to work with that group again, possibly on quality risks. I know that they'll be moving on to other things now, onto people risks, but I think it's such a valuable piece of work. And thank you so much for the group to the challenge that they've offered us as an organisation.
Thank you. That's really strong message I'm seeing, and I'm hearing several things here. I'm hearing the importance that we all feel as board members of actually sharing our vulnerability as people who are users or carers or in other ways associated with the service. That's something that's coming across, and the importance of that psychological safety, but also picking up a point as well in a way that Rachel's developing that one. We need to think as well about us as professionals actually becoming vulnerable and losing power in a way as a result of them being open to hearing other things. And I think that's something that I'm hearing that from Suzanne has had a big effect. I think I've got several questions two big questions to ask. One of which is, how do we make this scalable? You know, we've asked a lot of you, and you've delivered a lot. But actually, to get across that whole organisation, the amount of time it's taken for you to be able to make that contribution is something that we have to really value, and we've got to be careful and respect. And yet, so that there's a question there, and there's also a question about, you know, you say that this is the only one that we know about this now. How do we as well make this so that it is more generalizable across the NHS, and so that we can act as something where we help other groups do this sort of work? So there's the two questions I have. Thank you. Sally.
just sort of responding to some of that of how we might develop it in the future, and that we would we've been doing it almost retrospectively, looking at risks, but in the future it would be great if the committee works with the board subcommittees to look at risks as they're developing, so it's much more of a kind of proactive rather than a retrospective activity. And I guess it's also good to reflect on that this is one of the aspects of involvement across the organisation. This is at the board level, but there's a whole branch of involvement, and projects had that from the start.
Bottom control here. Thank you very much, and thank you, Hugh, for the presentation, and Chris for turning up, and Neil for making this all happen. I think this is something that's going to be quietly transformational for us, and to be good. Thank you. Okay, we now move on to our board assurance framework update. Ife, are you presenting this?
Yes, I am. Thank you, Chair, and morning, everyone. So I think the paper is succinct as it is, but I just want to highlight a few things. You will recall that at our May board meeting, we reviewed each committee risk in detail, and the intention here is certainly not to do the same, but I hope we'll do so. I think it's likely to be at our November board. There are 13 risks on our BAF. 4 of them are significant, 6 are high, and 3 are moderate. You see the detail in the paper. There are only 2 things to draw attention to. One is that the Business and Infrastructure Committee closed the risk on revenue and capital delivery for 23-24, and a revised risk, same heading, has been opened for 24-25. You will recall this is what we agreed, that there are likely to be some risks on our BAF that are in-year risks and therefore need to be reviewed at the end of each financial year. And the second, which I hope we'll hear more about perhaps in November, is that the People Committee has agreed to treat the impact of service expansion as a managed risk. It is still a high risk, but we are, of course, as an exec, and the People Committee also receives report on this, doing everything we can to manage that risk. And that's all I wanted to say. Something that occurred to me as Hugh was speaking was whether at some point, if possible, it would be good to have one of our board strategic days with the Services and Carer Committee and ourselves in the same room, just thinking through some of these risks. You know, I take the point that Sally made about it being retrospective. I take the point that Susan made about how we often look at this as risk to the organization, but can we get to a point where we think more broadly about some of the risks to individuals that we serve? And I wonder if their presence, as we discussed, that would help us do that better. That's all I wanted to say, Chair. Thank you.
Thank you, Ife. Any questions or comments? Ben.
Just a brief comment. People will be aware how long the risk on pressure on district nursing teams has been running. At the last Quality Committee, we've discussed downgrading that from the BAF, partly because those teams are fully recruited, and also because Ian has done some really sterling work with getting some more resource into those teams. So we're anticipating that next time we look at the BAF, that risk won't be on there.
Thank you. That's helpful, Jo.
Can I just commend everyone for that, because that is phenomenal. You know, both sides of that equation. So, you know, we know it's a difficult group to recruit. It's not an easy role. So to actually have those teams largely recruited is a phenomenal. You know, I know we don't just go, oh, that's good, we're there. It's ongoing, but that is really good. And to achieve some extra funding as well. Where we know that's been, you know, a very difficult hole to fix is a really, really good effort. So well done, everyone involved in that.
If you want to comment, Ian, and then Steve wants to comment.
It's very kind of Suzanne to congratulate me. I mean, Sarah Birchall and her team have really led those conversations. And the only thing I wanted to add is that there is a real commitment from at place, so both in Bexley and Greenwich, to look at the place of district nursing in the kind of wider health system and think systemically how we can think about the kind of ongoing pressure that those teams experience, and whether there's another way of addressing that by working much more closely in partnership, particularly with primary care, but also with our acute colleagues as well. So.
Steve?
Thanks. First of all, good to see it's running at around 13, 14 risks on the register. And as I've said before, that's bang on the mark for our external auditors' advice to maintain a good level of focus. Secondly, as Sue will be well aware, it's also good that the number of significant items, if you go back 12, 18 months, we had 7 or 8 significant items, which was the highest we'd ever seen. It was a bit worrying, but that seems a bit more moderated now. And thirdly, on district nursing, if I have one concern at all about the BAF, and I do take what Suzanne was saying earlier about we need to reflect on service user input, although I think that's going to affect the quality, the committees more than the strategic risks, but that's for another day. It's just around some of them were straying into the business as usual sort of area because they've been on the BAF for a long while. Having said that, mitigations had changed. There had been some changes. Restraints would be a good example, and district nursing had been on there for a while. So I'm absolutely delighted that Quality Committee have made that decision in that sense. And also, as Joe and Susanna said, fantastic work from Ian and the executive to get to that stage. So just I think just we need to be careful about it. If for some other risks, have they been on there just too long now? And in fact, we've got to accept them as business as usual. But generally, that's a good BAF that we can focus on.
Thank you. And I think we always have the tension in the NHS that in many businesses, risks that you wouldn't tolerate, we have to tolerate because we're a public service, which makes life more difficult. Iffy.
Thank you, Chair. I just wanted to add to the comments about district nursing that I have agreed with the place lead for Bexley, who is minded to procure an independent review of our Bexley district nursing. I think that would be a good thing to help us and them in particular understand why we've had this pressure for several years, and I don't think that pressure is relenting at all, to then guide us as to what other changes we can make, particularly if there are interface issues with primary care, which I suspect that they're likely to be.
Thank you. Any more comments? This item is for us to agree the board assurance framework, but we are going to have a fuller discussion as presaged in November. Thank you. Okay, we now move on to reports. We start off with the chair's report. So 2 months in, what is my report? Well, I think one of the things I can report that I've got to know South East trains particularly well. As I've been going around visiting all of the various services, I'm even sort of getting to recognise different types of train now. I could become a train spotter in my old age. But I've spent a lot of time visiting services, which has been really interesting, and that's mostly been you could say frontline clinical teams, but also beginning to meet other groups who are really important for the work of the trust and for the future of the trust, who are not clinical teams, and I think I need to do more of that. I think I've managed to visit now all the major sites, all the large sites, except for Goldie Lee, which for reasons had to be postponed, and had a real chance to meet staff and also people who are using our services. There've also been some set piece occasions that have been really good to meet people. The Tea for Trust of the Year's Nurses Conference, a particularly enjoyable Sports and Activities Day for Learning Difficulties Awareness Week. And I've opened a football pitch. I've never done that before on the first day of the Euros at Bracton. And then with IFI as well, the Bromley Mental Health Hub sort of opening of their new facilities there and seeing us working really closely in collaboration with Mind. And what I was particularly impressed with there was that you actually couldn't work out really who was Oxleas staff and who was Mind staff when, until you poked. And that I think was a really strong message. I also started to meet external stakeholders, which has been interesting. Richard Douglas of the ICB, I think we should probably, people aren't aware he was knighted in the last honours list, so perhaps we should send him some official congratulations from the board. We have done already, good. We're ahead of ourselves there. Caroline Davis from NHS London. I met with Norman Lamb yesterday and the Greenwich Health and Wellbeing and also the London chairs. My reflection on that is that we as a body are well regarded in general by these people, but we're not top in the whole of their list of worries. And I think that what we've got to slightly think about is what is the ask that we want of these people. There are innumerable ones of these committees and bodies that we are represented on that are our stakeholders. And we need to think about what is the, and sometimes we tolerate that, and maybe we should manage that a little bit more and understand what it is we want to ask of them so that they can do it, and think also about what are the solutions that they ask. So, for example, probably we should minute this lightly, but it's public information, but minute it lightly. Caroline Davis is really keen on getting into community. Claire, thank you. Getting into community work, and how can and is keen to ask us how we can help her do that. So I think there's work that we can do there. I think the other thing that we also need to note on is the fit and proper person. We have made our submission to the fit and proper person. Thank you everybody for filling in the forms and responding to that one. Another part of the job I didn't know that came with chair was the need to check people's social media posts. And as somebody whose Twitter account could probably be marketed as a cure for narcolepsy, it was certainly thank you for sharing your social Twitter feeds. I've also undertaken bits of training on things, but I think my summary is that it's been a really helpful 2 months, and now I think very much engaging with the team within Oxleas, now beginning very much to engage with the stakeholders, and I think we should be in a good position. I'll be in a much better position in the next few months around thinking about how do we as a group, we as a board, want to shape things going forward. What is it that we want to tweak in order to move things forward? Any questions or comments? Sorry, that was a bit of a long list, but any questions or comments? No, in that case, Iffy, can I please turn to you for the Chief Executive's report?
Thank you, Chair. Just a few things I want to highlight from my report, but I will, of course, be happy to take questions on what I say and all the content of my report. So you will know junior doctors completed their strike on Tuesday morning. Certainly had an impact on our provision of services. Can you hear me okay?
Yes.
Yeah. Had an impact on our delivery of services, impact on clinics, many of which were cancelled. We did manage, however, to provide adequate out-of-hours cover at some cost, the detail of which I'm sure will work out in time to come. I am, of course, grateful, and I'm sure the board will agree with me, that we're grateful to clinical staff and non-clinical staff who have supported us, not just on this occasion, but also on previous occasions. I am afraid to say that there are likely to be patients whose clinics have been cancelled who will be upset by this, but I think part of the work we need to do is to try and make sure that we rebook and we see them as promptly as possible. I think in time to come, we'll hear more about the wider impact of the strike on the NHS. And I certainly do remain hopeful that irrespective of the outcome of today, that we will resolve the issues with junior doctors in England, particularly as resolution has been sought and found in the other nations of the United Kingdom. The second thing that I want to raise is on the maintaining focus and oversight of quality care and experience letter received last week. This was on the back of a BBC Dispatches program, and I'm not sure how many board members saw it. I didn't see it on the day, but I've come back and seen it on Channel 4, which was really very poor and very concerning, where an undercover support worker spent 3 months at the Royal Shrewsbury Hospital and recorded a lot of the goings on within the ED department, mostly to do with fit to walk wards. I didn't know that existed, and what we've always known to exist, which are trolleys lined up in corridors with some people waiting sometimes for up to 2 days. And the video or the film showed poor staffing levels, poor resources, really poor infection control practices, I would say, and people's dignities were just not respected at all. So we, like I said, the letter came through last week. We haven't had the chance to review it, and I'm sure the board has requested, but I hope the board will agree that it is right that we, as an organization, go over services that we know can be pressurized. We've talked often about people in ED, people on our acute wards, etc., and that the paper will go to the quality committee, and in turn, a summary will come here for the attention of the board. The Synovis attack is written in detail in my report and also in Ian's report. I don't intend to go over that, other than say that we continue, by we, I mean as a system, continue to navigate our way through that. It's going to be a few more weeks, if not months, before that's resolved. Still on the system, I think it's fair to say that, as previously discussed, we are likely to, we have put in a deficit forecast for 24-25. We are one of 3 systems across London. There are 5 in London, 2 declared break-even. We are one of 3 that have declared a deficit, and the last report I saw suggested that London will have a total deficit of 255 million. I rather suspect it's likely to be higher, because this doesn't take account of the strike by junior doctors, and it certainly doesn't take account of the Synovis attack. If you look at my report, you'll see how many electives have been cancelled, and that will have a financial impact on those organizations, let alone the impact on lives. I want the board to note the agency rules. We're doing a lot, and I am grateful to Rachel, Claire, and to Azra for the work they do on our agency panel. I think that the most challenging for us at the moment is medical agency, where we really are struggling to come under the rates that's suggested. Abby and I met with higher trainees who are coming to the end of their training in psychiatry, I think a week or so ago, just to understand what more we could be doing, quite apart from literally asking them to please apply to us. I think about 50% are keen to, others not because they don't like Oxleas, but because they have other plans, family-related plans, and some want to take a year out before they consider consultant jobs. But we continue to do all we can to attract and appoint substantive consultants to reduce the demand on agency. You will see from the report that our agency spend as a proportion of our total spend on staff is still reasonable at 5.5%. Some good news and celebrations, 3 of them in my report. One, of course, is the Pride Parade that happened on Saturday. The other is the nurses, annual nursing conference. Thanks to Jane and colleagues for putting that together. Andrew mentioned that in his report. I think that Lawrence Young was well celebrated. 52 years in Oxleas, that's impressive. and I'm really delighted that he was given a lifetime award. But I'm also very delighted that we have 2 awards. I hope we'll win them in October when the results are announced. One is a well-being. One is an award for employee well-being, and the other is a personal award to Rachel Clare, who I'm sure is squirming right now. I can't see her so well, but I was only too happy to attend a meeting where, along with another colleague, we spoke very highly of her efforts and her accomplishments in Oxleas, and I'll be rooting for you, Rachel. And that's all I wanted to say, Chair. But like I said, I'm happy to take any questions.
Thank you. And noting Rachel's embarrassment, but we will move over that. Well, I think we would all join you in that. Other questions or comments for Ife?
I can't add to Rachel's embarrassment. Fantastic achievement. And it's also a good bridge to the HFMA and what Ife was saying about budgets, etc. The HFMA recently had a conference for finance directors, and they passed a motion asking for NHS figures and budgets to be more realistic, and in their phrase, because we can't achieve unachievable goals. So as if you will know, certainly in the London area, 100 million is going to be an enormous stretch for South East London. And I can tell you that the other organisations that are more than 100 million equally, there'd have to be no industrial action, everything go fantastically well, and some recovery on elective care, which Ife has already touched on. So, I think, first of all, to recognise we are in a great place for Oxleas and how well run Oxleas is, clinically, financially, executive-wise, audit-wise, not personally audit-wise, but internal audit report-wise. But certainly this is going to be a very difficult financial year, and that we will have challenges as to what scale we want to support the system. That will be a bigger debate for another day. But the main point is just in terms of looking at the broader scene, the finance director's view at the HFMA conference, there isn't enough realism in the system to what can be achieved.
Thank you. I'd agree with that, Nina.
2 questions, please. I'm conscious that we are now in the 2nd year of industrial action, and we have said around this table a number of times that NHS London or NHS Central is bringing together data on patient harm. Presumably we still haven't seen anything, and I'm just increasingly nervous that we don't have visibility over data relating to our own patient harm.
We haven't seen the data yet, and I'll bring that up at the next meeting that I attend. It was going to be coordinated regionally, and we were asked to make submissions. And I think they've learned from the industrial action, because with Synovis, they've actually set up a weekly, is it fortnightly or weekly meeting to look at harm. So there's a better process for the Synovis than there is for industrial action. So, and yes, this was the 11th. Right. The first one was February 2020.
Yeah, I'm just feeling increasingly uncomfortable that we don't have visibility over data in order to be able to form a view on patient harm. And it would be whatever is happening regionally, I would really welcome being able to do a little bit of a deep dive. I realise our tools to be able to mitigate are limited. We've had that discussion. I just feel a bit uncomfortable not having visibility.
So in terms of harm, the harm is divided into immediate, medium and long term. So the immediate harm is you're cancelling clinics. And so we know the number of clinics we've cancelled, how many patients have been affected. We've cancelled podiatric surgery as well. So we know that in terms of immediate harm, we have that data. But medium to long term harm will take a bit longer to sort of determine whether it's associated with or was actually caused by. And causality is very difficult to determine.
Yep. The second question was around the new agency rules, and I'm just, I forget the specific wording, but there seems to be a very explicit carve out for, so no use of agency for admin and estates workers. And I'm just conscious that we have an agency worker on fire and have had for a very long time. So, and are likely to continue to need to follow that model. So, what are we doing to make sure that we balance the rules with being able to deliver fire safety?
I mean, at the moment, that person is still on agency, and so at the moment they're still on agency, but our plan, hopefully, is to get them onto a short-term contract.
And just in terms of visibility of the monthly report, I think it's referenced as being on agency uses and agency usage and breaches. Can we just make sure that that's coming up through committee at the level at which it needs to, so that we've got visibility? I'm happy for it to come to people, but I'm equally happy for it to go anywhere else. I would just like to have that visibility given the background of these new rules, please.
Happy with that?
So it goes to people committee or to sorry.
I think so. Business and Infrastructure Committee, we see the financial implications and we track the financial implications. I think in terms of the approvals, the criticality of who's over the limit, that probably fits better with People Committee because it is kind of related to more people issues. So I think that kind of dual approach works for me, I think.
So we're happy with that going forward, and we'll get a report from region on the harm or potential harm as well when Abby's able to excite that out of them.
Thank you.
Thank you, Jim.
Thanks, Chair. Just one quick question, Iffy. I note in the report you say that NHS appointed the first medical director. How does that affect us? And is there any effect on us?
Sorry, I skipped that because I talked about that at our strategic away day. Well, I think it's good news. I think it's good news more broadly for the NHS. It's the first time we actually that mental health has had a medical director appointed. And it's not just for mental health, it's also for neurodiversity, which I hope will help us to get a handle on the rising numbers of neurodiversity referrals that we're getting right across the country. How does it affect us as Oxleas? I hope that this will ensure that the whole conversation we're having for years now about parity of esteem will be maintained, and also that mental health will be considered along the same way that acute is considered when it comes to funding streams, etc. So it's a really positive thing. What we want to do in Oxleas after this conversation with Sally is see whether we can invite him along to see some of our new models of delivery. Colleagues who were at the Council of Governors last week will know that the ASD, ADHD presentation we had from the team was really very good. And it wasn't just about the work they do, but it's also the constitution of the team. And that, I think, is the sort of thing that we can showcase right across the country, both in terms of how we, an employer, appreciate people who are different, but also how their lived experience contributes to the care that they deliver. So I'm hoping that we can engage with him and he can then use us as an example of how services are run and invite us to discussions or roundtables about any issues that need to be addressed going forward. And I did say the last time that he's the brother of one of our former maids, Steve James.
Thank you. Any other queries or comments for Iffy? No, thank you very much. So now we move on to Rachel. You're introducing the trust strategy.
Yes, very, very excited to be bringing hopefully a near final document now for your approval. And what I really like about this whole process is just how many people have been really actively involved in the creation of this strategy. Many organisations pay an outside organisation to go away and draft something. Some have hugely staffed strategy teams, which I'm sometimes a bit envious of. But the upside of the fact that that's not how we approach it here is I can say absolutely hand on heart that every member of the exec and all of the people in the board and everyone has really actively played a part in this. And it feels to me a bit of a labour of love about setting about the new direction for us as an organisation, which builds on some considerable successes in the past, but really, hopefully you feel is both ambitious and achievable. But that's been a real team effort. And I think that will also contribute to its delivery and its success, because we're not starting a process now of starting buy-in. The buy-in has been the progress of getting to the position that we are. And it means that I think we can actually really start to motor as we take forward these ambitions. As you know, it reflects some changes of priority. It reflects some changes to the areas that we consider important and the challenges that we have, but it is very much, we hope, recognisable to people who are very familiar with and supportive of our original strategy. So there's more focus on clinical innovation and research. We are much more explicit about what we mean about great care. There's much more there around sustainability, productivity, and being a force for good in local communities. And we've also taken on board feedback about kind of simplification of language around great care, timely care, and best place to work. And we had a really good discussion in this room at the board strategy away day, which is one of a number of different people that we've engaged with across the piece, including governors and members and service users and local communities and place leads and people in our prisons, and a whole host of different people have helped us to form this. But one of the things that came out of our discussion in this room was about wanting to be more explicit about our ambitions on equity, and particularly around health inequalities. So hopefully what you see in this document is really quite as well as the really important things like capturing better data that enable us to be much more targeted. It also says these are the areas we already know we have a problem and where we are wanting to work on. So hopefully that's come out. You can see that coming out clearly in response to your feedback. So once the document is agreed here, and there are a couple of tiny changes that people keep kind of suggesting to me, and I'm just going to run through them here in the hope that you don't mind me just tweaking them slightly. We're going to add a bit more reference in partnerships to HMPPS and NHS England. We might tweak the wording around body-worn cameras to reflect ongoing discussions within the organisation. We're going to bolster a sentence about education, and really helpful feedback from some of our governors is that they really like it, but it kind of ends with a bit of a whimper. It kind of doesn't wrap up nicely at the end. So we're going to be thanking people at the end for those who've contributed to this, just so that it kind of wraps up the document, but nothing which goes, I'm not suggesting anything which goes to the substance of what's in there. And once we've done that, we will then communicate it. Sally's created a great communications plan that you've got in your pack to really bring it to life to people in a range of different ways. Some people like animations, some people like summary documents. We will do it in a way that we can use it for induction and a whole host of ways that people can get up to speed with it quite quickly. And a bit of it that I'm excited about, which we didn't do for the last strategy, is that I'm going to be working with each directorate over the summer to come up with a 1 or 2 page summary of how that directorate contributes to the strategy. And I just think that will help people, given the breadth of what we do, to draw that dotted line between what they do every day and to see how that contributes to our overall strategic direction. So I'm looking forward to doing that over the summer. It is an ambitious strategy, but I still think, coming back to Andrew's point this morning, there is still more thinking we might want to do about what our ask is of the wider community and system that we work in. So we're not going to kind of put this away in a drawer and not keep it as a live document, but hopefully what it does is set out a clear direction of travel for us as an organisation overall. I am really grateful to everybody's involvement in it. There are many organisations I've worked in where it would have been really hard work to get something like this finalised, but in this organisation it has genuinely been a joy because of the enthusiasm and commitment that everybody from the organisation, from the board to at all levels, really wants to contribute to making Oxleas the best place that it can be, and I find that quite humbling. So thank you very much.
Thank you, Rachel. I think, accumulation of immense amount of work, not only by you and your team, but actually by the whole of the trust and people around this table. So thank you for that. Questions or comments? Shall we first of all start off with questions and comments about the strategy, and then maybe follow about how we then take it forward? But Steve?
First of all, Rachel, thanks for all the consultation. You could not have done that better. And I was particularly pleased to see Sally's communications plan at the end, because at the end of the day, if we don't communicate this to our stakeholders, it's not worth doing in a way. People have got to know what we're doing. Two questions. First of all, you've touched on inequalities, I know, within the document, and also children's services. And it just made me think about if you, in conjunction with Ian, could distill some thoughts about preventative measures that we are undertaking at a strategic level. That'd be really helpful. And secondly, and this touches on both inequalities and inappropriate referrals, our relationship with GPs, and this crops up in the board visits later on. We know that many of our services have referrals from GPs that shouldn't be coming to us, so that gives us resource issues in dealing with that, and also discontent from possible service users that we may turn away. And secondly, the distribution of GPs. I realise that may be beyond our control, but that is such an important area. Tunbridge Wells has, and it's not an area, but it's 2-3 times as many GPs as anywhere else in the country. And I think we have the same distribution problem between Bromley and Bexley. So although we probably can't do anything about that directly, what are we doing in our relationship with GPs to perhaps ameliorate that inequitable distribution of their practices? But secondly, I think more importantly, what can we do with GPs about referrals that shouldn't be coming to us?
Thanks very much, Steve. Ian and I have discussed this beforehand, and he's going to kindly respond to those points.
Yeah, thank you, Steve. I'll start with the GPs first. So I think operationally across mental health and community health, there are structures in place led by the directorates to kind of manage that relationship with general practice. On the mental health side for adults, the introduction of the hubs has helped, I think, in terms of better advice and signposting of people presenting with a mental health need to where they are best going to receive the appropriate help. And that is already starting to have an impact on, for example, our non-psychotic pathways in ADAPT. And then the additional thing in adult mental health, of course, has been the introduction of primary care mental health workers. I think the introduction of these posts has been slightly different across the different boroughs, but certainly in Bromley and Bexley, they are helping to kind of add capacity and capability within general practice to kind of meet needs. I think the area where we would like to take that further is around the number of people who we continue to see on a long-term basis who do have long-term mental health needs, but they have quite specific medication needs, and we still struggle to kind of for them to be managed in primary care. So I think that's an going conversation. And certainly in Bromley around children's mental health, I have met with the PCN clinical directors recently, and they are quite keen to use the template of the approach they've used for adults to kind of do something different for children. But actually most of our children's referrals come from outside general practice. Some do, but we also get referrals from schools as well. So there's a big thrust within CYP mental health to look at how we scale up the good work we're already doing around school nursing, things like that. And then the last thing to say about GPs is the concept of working at neighbourhood is something that the ICB really want to accelerate. And what that means is they will be, and again, the rates of change are different across the 3 boroughs, but there's a real focus on how we bring services closer together around populations, eliciting kind of information from GP lists about the populations that they serve, but really importantly, and it speaks to your prevention piece, how we activate local communities who to do more to help themselves. And there's some really good grassroots examples of that going on in all 3 boroughs. So I guess there's something about how we support that work. And then as I've kind of talked about prevention, the other kind of very obvious bit of preventative work which we need to do internally is that needs to be woven into every clinical contact that we have. So there's an expectation that clinicians will be having conversations about how we prevent conditions exacerbating, or how we support our residents to manage their own conditions on a kind of long-term basis. So that's a kind of another dimension of it, which is just implicit, should be implicit in every clinical contact. But that kind of wider prevention work is, we are trying to weave that into our BAFOS strategy and thinking about what our role as a secondary care provider is in sort of helping the leadership of those conversations, but also being mindful that a large part of that sits within public health. Probably more than you wanted, but
Got the thumbs up there. Iffy.
Thank you, Chair. And Ian, thanks for that. I think you responded to that question quite well. I just wanted to add a few things, if I may. So I think you're right about prevention not being explicit in our document, but Ian has made a point about the role of clinicians, and I would go further and talk about some real health challenges, smoking cessation, for example. That's one of those things that we, our clinicians, particularly for those with mental health difficulties, continue to grapple with, including exercise, reducing social isolation, etc. But I also wonder whether we could beef things up a little bit more when we talk about being a force for good in our local communities, because as Ian has said, we certainly support communities to think about ways to self-manage, and we could do more in that space under prevention. I think for the GPs, it's absolutely true, and I think it's the right thing that a lot should happen in local care partnerships. But I recently attended a Bexley GP meeting, which I was invited to, and they talk a lot about missing us. It's almost as they want us to reintroduce those GP master classes where we can talk about specific topics, which was something we did before the pandemic. But I think we'll probably want to restart those again. Avi and I met with the senior leadership team from Bromley Healthcare a few weeks ago, and there was also that conversation about the need to do something jointly with GP in Bromley. So I know that we have done this before. We've got the template, and I'm sure we'll be able to do that again.
Thank you. Jim.
Thanks, Chair. One comment and then one question, Rachel. The comment is that I know it sounds quite strange, but when I read the strategy document in totality, I was really impressed with the ambition and the drive, but I was actually quite touched with what we're trying to achieve. And this is really a step change from what we've done before. So, I mean, I really commend you and your team, Rachel, because I've read it avidly. I read it twice even, and I really, I agree with virtually everything you've written. The quick question really then is, in terms of the strategy, in which part of the strategy do we sort of address maybe microcultures, the sort of things that we've been seeing? And is that part of sort of best place to work, but is that addressed in any way?
Thanks. Yes, it's definitely part of best place to work, because I think whilst we want to have a really positive agenda around the nice, good things that we can create, we also need to recognise that if we don't tackle the stuff that really has a direct impact on people day to day, then quality of care will really fall. So there's a lot in there around, for example, around what we do around violence and aggression, what we do around investigations, but also that kind of what I think of as kind of when team cultures have become toxic in some way. And we're actually shortlisting today for a new role which brings together the improvement and transformation and strategy and organisational development activity across Vicky Woods' team from a quality perspective, with my team from a kind of from a people culture perspective, because we recognise that getting those cultures right is at the heart both of quality and staff experience. And previously we've been doing similar things, but we haven't been completely aligned. So yes, that ambition to have a toolkit, there's quite a lot of detail, I should also mention, under this, which will be part of our people strategy. We want to have a toolkit and a set of interventions that we can readily deploy when we know that a team's in trouble. And one of the places that we identify that, for example, might be in the meetings that we have with Simon, who's here from our Guardian service. We also meet with Joe as SID, and with IFI, and with staff side, and with the feedback from the CQC. And we're able to start seeing the pockets of places where we know there are problems, and what we want to do is to get ahead of that by having interventions to try and sort those issues out.
Then if you're ready to move to the process bit rather than the content piece. When I read the cover paper, the one thing that I was thinking about was how we keep our eye on the progress of our policy. And I did have a very brief conversation with Rachel beforehand to say that I was going to think about how the Quality Committee consistently ensures that what we're hearing from services reflect the strategic direction that we want to travel in. I understand from Rachel that her most up-to-date thinking is that she's anticipating that each committee will be doing that.
So yes, let's move slightly on to the processy type things, and and also I think, as well as the committees, the thing that Rachel and Sally and I have talked about as well, about how do the board do this forward. So perhaps you could wrap all of that together, Rachel.
Yes, thank you. And I should have probably said when I was talking about strategy more generally that the work that Sally and Rachel Townsend have both done has been absolutely instrumental in where we've got to. So there's been lots of positive words. I want to make sure that you understand the big role that they played in all of this. So going forward, so the role we played with the last committee was that we had a rolling programme of areas of focus, both of the big priorities and what was then the building blocks that would come to the board. And I think it is important that the board has oversight of the direction of travel. But I also think if everybody's up for it, I think having committees owning particular parts of the strategy so that they're really able to kind of look at how it's progressing, able to escalate areas where they think there might be blockages. I think that would also be useful as well. And that's not quite how we approached it previously. And that my sense is, I think that that committee involvement in really driving it could be really important. But I think we would also want to make sure that we've got some time to also unpick perhaps the areas as a board, particularly at kind of strategic away days, that might, I'd love us to be having really active conversations about the direction of travel. So I'd also welcome the committee spotting those kind of wicked problems that we might want kind of collective discussion about, so that it can feel as though we're all kind of in there thinking about how we can be as ambitious as we'd like to be.
Are we up for that? Yeah, I'm getting smiles around the table, which I will take as nods. So I think, the details to be worked out, but that sort of direction of travel, I think, would be excellent, because I think we've got to really live this at the board level, and push it. I was interested as well. You're saying you're going to get the directorates to do a sort of 2-pager. Presumably, that would also include non-clinical areas as well. My question is, and this is an open question because I haven't thought it through. Is there a way, would it be useful to also cut that in some other way? So, for example, amongst professional groups, I'm thinking AHPs, nurses, doctors, medics, would that be also a useful way to do it, to try and get some connections between directorates that way? Question mark.
That is the plan.
But that is the plan.
Yeah.
Okay, thank you, Jane.
In our last nursing strategy, we firmly aligned it to the trust strategy so that there were really clear overlaps, but we were able to nuance what we needed for the nursing profession explicitly. It worked brilliantly.
For the medical profession, we've linked it into job planning, so that people are able to demonstrate, and as part of their objectives, they need to be able to say what they've done towards that.
Thank you. That's really good. So so we get that cross-cutting, because people have professional loyalties as well as directorate loyalties. Joe.
The wording of the strategy, and I agree with Jimmy, it feels like us, and it's ambitious. I particularly love the definition of great care, and about people being there, humanity. I think that's a very all-encompassing way of talking about it. Thank you for putting some specifics in on inequalities in services. How close are we to having good baseline data that we can then track against? Because what I don't want us to do is take 2 years really to get baselines.
Please go.
Yeah, so we met as a Bathos group. Was it the beginning of this week? Gosh, feels like a long time ago. And Simon's team presented some data around demographic data around protected characteristics per directorate. And I'll be honest, Joe, it's a very mixed picture. So particularly around race and ethnicity. Across most directorates, not necessarily all, I think adult learning disabilities and forensics stood out as having better data, but we have high percentages of people where either race and ethnicity is not known or not stated. And my concern is that where we have got ethnicity stated, it suggests we're seeing a lot of white people, which is clearly not a reflection of the communities we're serving. So I have had a kind of emergency meeting with Bathos leads, Neil, to really think about how we're going to accelerate getting that data. I think the approach that we've taken is that is to, in a very Oxleas way, try and understand what some of the barriers are to getting that data. So we need to understand that for people who use our services, they may not be comfortable in sharing that data. So we need to be kind of clear with them why we're doing that. And also we need to support our staff in having those conversations. But that also needs to be balanced with the need to just get on with this, because if you benchmark us against other certainly other mental health trusts in London, we are behind. And I think we've just got to get that kind of combined approach of you've just got to do this whilst being sensitive. So that is the message that I have given. Neil, you were there. You can back me up on this. So.
Sophie.
Yeah, so 2 points really. First of all, just to say how I agree with colleagues about how clear this strategy is about what we've achieved and also our ambitions. Just to pick up on that inequalities point as well, I completely understand about the need for benchmarking data, but if we're trying to send a message with our strategy, and that message is that we want to address these inequalities, I think we just have to be explicit about it. And as Ian says, we just have to push forward. I mean, my slight hesitation was about religion. We talk about the lack of Muslim communities accessing talking therapies, for example. And if we're not able to gather race data, it's very, very difficult to gather data on religion. But again, I just think we have to come back to, we have an ambition. We need to achieve that ambition. And this strategy is sending out a message about what we want to do. And that kind of relates to my, well, it does relate to my question, which is about the engagement strategy, about how we're sharing this. I think it's really good that we've got it set out. I would like to know if we're thinking about what we're trying to achieve with our engagement. It's great we're trying to share it, but do we actually want to achieve something by sharing it? Do we have a social media strategy, for example? Are we using this potentially as a recruitment tool? Rachel talked about using it as an induction tool. I think this is a great recruitment tool. Could we possibly think about how we adapt it and get it out really, really across social media as well as more traditional channels? And the same for engaging with communities. Are there any bits in there that we want to pull out, and that rather than just sending it out to communities, which is wonderful, that we also really think about, do we want to target any in particular? Because that's a two-way street then. People feel involved, they feel as if they've been recognised within this strategy, and they're therefore more likely to engage. And the same with partners. We're looking for new partnerships. There's a great bit in this strategy about that. This could be used, just sharing this strategy or sharing a specifically targeted piece of this strategy to potential partners. It could really open doors for us. So just thinking about the strategic strategy engagement plan, I think would be really helpful.
Sally.
Thank you. I mean, firstly, for the channels, yes, absolutely. We'll use the channels and build on the channels that we've already got. So, we have a strongly followed X account and Facebook. And also LinkedIn is used very much around recruitment. So using that, I guess the first step is sharing and raising awareness about the new strategy. But absolutely, it's about how can we garner the resources out there to help us implement it. So I think that more targeted aspects and actually building on the roles of the committees with taking forward certain aspects. I'd be very happy to kind of talk with the committee chairs about particular aspects that they're trying to take forward, and then how we can do a bit more of a bespoke comms plan around that to help those particular ambitions. And I think it'd be worthwhile having a conversation at our involved group, particularly around the communities aspect, to see how we can take that forward and what other work streams are going ahead, particularly within partners, that we can build on rather than trying to do things ourselves in parallel. Thank you.
Thank you. Well, I think we've had a really good discussion, and what I'm hearing is a ringing endorsement of the strategy as it is, and a thanks to all of the people who've done it. There have been some comments, and there are some comments you've already got on the desk, and I think I'm reading it that we would be happy for you to incorporate those as you best fit, but that we are approving the strategy as is, subject to any minor modifications in light of this or other discussions you've had going forward, approving the plan going forward, but hearing Sophie's point about having that ambition in that plan of communicating it, of using it more widely, and of thinking through work to be done, but thinking through perhaps a bit more how the board and the board subcommittees will be able to help embed that strategy in Oxleas. Is that a fair summary of where we're at? Thank you. Well, I think congratulate everybody involved, which includes ourselves. So we can have a moment. Now, we'll probably do a break fairly soon, but I'd like to just do one more item, if that's okay, and then we break for coffee for a variety of reasons. And so I'll invite Ian, and then after this item we will break. I'll invite Ian to do the operational report. Thank you.
Thanks, Andrew. So as usual, there's a lot of detailed information in the reading room, so you will see the narrative report from each directorate starting on page 24. Alongside that, you also have the detailed operational performance report and dashboard, which was also shared at June's Quality Committee. But on the front sheet, I've tried to highlight a few things that I thought warranted the board's particular attention. The first two things are really fantastic developments, which I think are a real evidence of operational and clinical innovation. The first is that after quite a bumpy kind of lead in, I'm really pleased to say that the urgent community response car, which we are jointly operating between the adult community physical health team and the London Ambulance Service, started on the 18th of June. As the report indicates, it's quite small scale to begin with. It doesn't cover the full 7-day period, but we are hopeful that with the participation of Lewisham and Greenwich Trust, it will go up to 7 days fairly soon. Already, as it said in the report, within a few days it had seen quite a number of patients. And I think it will really be positive in terms of enhancing our existing urgent community response, but also really being an offer to the system, both in terms of faster access to appropriate community care and hopefully reducing pressure on ED. So fantastic piece of work, and I think the directorate are rightly excited about it. The next thing, again, which is really excellent piece of innovation. Colleagues will remember that earlier in the year we closed our adult learning disability assessment and treatment unit, Atlas House, but some of the kind of resources have been reinvested in enhancing our offer to adults with a learning disability who find themselves in inpatient mental health care. We've established an ALD liaison service, which is really supporting inpatient colleagues to deliver tailored support and treatment for people on our acute wards. And again, it's very much in line with national policy, and it's a nice bit of inequalities work in action. And then the other aspect I wanted to highlight is that there's quite a lot going on within offender healthcare and forensic services. As it says in the report, the contract for HMP Cookham Wood commenced at the beginning of this week. I should just say, just for clarity, because it was quite a changing picture in the lead up to the mobilisation. It has been named HMP Cookham Wood. However, it is operating as an annex of HMP Rochester. And what I mean by that is that receptions will continue at HMP Rochester, and then there will be multidisciplinary kind of selection process to then transfer prisoners from the Rochester site to Cookham Wood. But because it has a separate name, it has required us to register it as a separate site with the CQC. So that was hurriedly put in at the end of last week, and grateful Iffy for signing that particular letter for us. The actual operation of the site won't commence until the 22nd of July. So on Monday, Sunita, the regional service manager, met all the new staff and started the induction process, which went really well, actually. And I think it's fair to say that I think for some staff, it's probably feeling like they're coming back to Oxleas, because a number of them have worked in Oxleas prior to going to CNWL, and now they're coming back to us. I think for other colleagues, I think there's some work to do to make them, to reassure them that Oxleas is indeed the best place to work. But in terms of the kind of prisoners, 30, it will go up to 30 on the 22nd of July. As I think I've said before at committee and here, we have made it very clear that we cannot go beyond that number until we've received the controlled drugs license from the MOJ, which can take, as I think I've said before, 3 to 6 months. So once that happens, we can then start to kind of build up the numbers. But the plan at the moment from HMPPS is that it will only go up to 70 until April next year, and then there needs to be a big bit of environmental work done before it can then go up to the full roll of 180. But I just wanted to thank Sunita, John Boyle and others for a huge amount of work to get this done at breakneck speed, and we will now obviously start the process of staff consultation. Sticking with offender healthcare, and it wasn't in the report, but I wanted to just highlight the situation at HMP Wandsworth. Colleagues will have seen press reports about an incident there where a female prison officer was suspended and has now gone to court for alleged sexual misconduct with a prisoner, which was filmed by another prisoner. So HMP Wandsworth was already subject to an urgent notification, and there has been a change of leadership in the last month. Andy Davey, who was the governor at HMP Elmley, has now started there, and I think he quickly noticed that huge systemic change, as suggested by the urgent notification, is required. And that includes levels of corruption within the prison, of which, this latest incident is yet another manifestation of that. So I think probably if we weren't having an election, this would be drawing lots of ministerial interest, and I would imagine whoever comes into government will quickly train their eyes on this. And of course, this is on the back of a very high profile escape last summer, and I think that is coming to court recently. But within that urgent notification, healthcare has been highlighted positively. The main issue for us is about enablement of prisoners to access healthcare. But with this recent situation, there are now real concerns being expressed by the team there around the safety of female healthcare staff alongside female prison officers. So the kind of huge escalation in kind of misogynistic abuse, a really quite tense atmosphere, and there was a rather unpleasant situation in recent days where a bucket of excrement was thrown over a prison officer. So real concerns about the safety of people working there. I wrote to Governor Davey last night just to kind of reiterate our commitment to working with him to support the ongoing turnaround, but I have highlighted mine and, I was highlighted the fact I'll be talking to the board today that we have concerns for the safety of our staff. I've also written to staff there, Oxleas staff there, and Bryony, the service manager, has outlined steps that need to be taken for staff to protect themselves. But of course, we need to then balance that with effective enablement. So it's quite a tense situation, which appears to be getting worse before it gets better. So I just thought it was quite important that colleagues were cited on that. And then the last thing I was going to highlight, which is more positive, relates to our forensic mental health services. I obviously talked to the last strategic board about the fact that we'd received the independent report into the culture within forensic services. Just to highlight that a summary of that report was sent to everyone working in the directorate, together with a covering letter from Iffy and me. We also put a short film together which features a number of the directorate management team and the exec, which again reiterates our desire to work with colleagues to shape our response to the recommendations of that review. And we have now started a series of meetings with all the teams across the forensic service, both inpatient and community. And these started yesterday. We had 2 meetings yesterday, which I understand went extremely well. Each meeting is facilitated by a pair of colleagues from the DMT, together with colleagues from the nursing directorate, and we are being ably supported. And I can't thank her enough, Rachel Townsend from Rachel's team, on the work around this. So these meetings are going to carry on over the next few weeks. We aim to capture feedback on how best turn the recommendations into concrete action. So it's designed to be a real piece of co-production. And the DMT, including myself, are meeting weekly with Rachel Townsend to manage this as a project. And we're also, as of this week, initiating a specific conversation between the DMT and the people team leads to take forward specific areas of improvement which might be needed, as highlighted in the review. And then the last thing is to say that I'm very pleased to say that we have been able to appoint to the role of Service Director for Offender Healthcare and Forensic Mental Health. And we have offered the role to somebody called Aisling Thompson. So we will have yet another Aisling and yet another Thompson within the Service Director group, just for extra confusion. But Aisling is known to some of us because she currently coordinates the community provider network in Southeast London. She has a lot of experience in healthcare up to deputy Q level. Her experience is mainly within acute and community services, and she has a clinical background as a physiotherapist, which is interesting. And we are hopeful that Aisling will be able to start in September, and I will be having a series of meetings before that, just to kind of help her get her head around what she's taking on. But yeah, I'm really pleased, and I think she'll be a great appointment in terms of bringing that kind of maturity of leadership.
Thank you, Ian. Questions or comments? I mean, I think the Wandsworth is a really challenging one, especially in light of us having just approved our strategy being the best place to work. What does that mean in that place? And I think that means that we really need to think that stuff through. But unless anybody's got anything, I think we would support you in your writing to the governor about it. But there's anything else?
Thank you for the update on the overall and on the forensic report. I'm just curious, do we have any feedback or any insights already on how the report on this from the culture review has been received by staff and their reaction to it?
Yeah, I think it's been received well overall. I think I've spoken to individual colleagues and who participated in the conversations with Joan and Nesta, the reviewers, and they feel that their views have been represented, which is great. I think prior to meeting with individual teams, there was a meeting held with, I don't really like this term, but kind of middle management, if you like, so kind of matron and ward manager level. And I think there's quite a strength of feeling there for various reasons. So I think we are very mindful, as well as kind of responding to the recommendation, to think about how we invest in that kind of strata of leadership, because we do rely on them, as I think we've talked about before. Normally we would rely on them to take forward this work, but they also may be part of the issue that we need to unpack. And I don't mean that in a kind of critical way, but I think some of the dynamics are quite enmeshed there. And I think within the DMT, I've been in, they're a great group of leaders, and I think this has been an opportunity to kind of bring them together. So they're very, very invested in getting this right. And again, I think there's a conversation to be had probably for myself and Rachel about how we can do more to kind of help them as a leadership team. But I guess, Manisa, the kind of key thing is, I think that the staff are pleased to be that we're engaging them and shaping the actions, but they want to see some action, and that's going to take. This is a kind of medium to long term project, I guess.
Thank you. Any other questions or comments for Ian? Abby.
I think it's more of a comment in response to Ian's what he said last. It's also about staff feeling that they're also part of the solution. It's not something that's just going to be done to them. It's something that's done with them, because we want sustainability and for it to be embedded. And I think that message has been passed across. It's how it's received, and we'll see that as we go along.
Thank you. Any other questions or comments? In that case, I suggest we have a leg stretch and a coffee if people wish that, and we'll re-engage at noon, if that's okay, for the last part of the meeting. Thank you, everybody. We're going to do a little bit of the rejigging because Steve has to leave by 12:30, but we'll do a little bit of the rejigging when we come to the committee reports and bring that forward, bring his committees forward, if we may. We'll now do the board visit reports, and so I'd ask. I'm going to have to unlock my computer again. If I'll ask people to give their reports, but again, really, as we discussed last time, perhaps concentrate on highlights or themes that you want. Assume that the ones are read. And I'm sorry, my computer's gone to sleep. So can somebody remind me who's the first? I also have too long a password. Sophie, thank you. So yeah. Over to you, Sophie.
Yes. So again, assume it's read. My first one, Green Parks House. I think what's I take from this is how teams understand and implement our policies, which we discuss frequently at committee and board. And what this visit really drew out was our policies on smoking, how staff, we may have a clear policy, but staff don't necessarily understand it and how it relates to them and their specific patient group. This was true for Scadbury Ward. The policy on racial abuse and how it's recorded, verbal abuse, how it's recorded, again, something we discuss a lot, but it came up here we don't have time to do it, data takes too long. So really good to see that that was picked up and is being addressed. And on contraband, what is allowed in and out of wards. And again, we do receive assurance on this, but it's really interesting to see how it is perceived by staff and how it's implemented. And this visit picked up and addressed all of those things. And finally, the importance of good administrative staff and a good relationship with the consultant that really came through on the Norman ward. That was highlighted, and you could really see it was apparent in the way the ward was running. So that's that visit, unless there's any questions or anyone has anything to add.
Nothing around the table, so thank you.
Okay, I'll power on to my next one then, which was the intensive home treatment team, again for acute and crisis. Also really interesting to look at the way a team works together and it perceives each other. And I think that's something that we get from these visits that we don't necessarily get from anywhere else. It was interesting that the managers told us that they felt it was a good team, but they felt that through an accreditation process, they'd had feedback that the team don't feel heard by managers. When we spoke to the rest of the team, they appeared to feel very heard by managers. And in fact, they highlighted specific examples of that. And I appreciate this can be the specific people you meet, but it was just interesting to see those two perceptions. And the thing I really took from this as well was how good management helps implement safety policy. And this was around people safe. I've heard about people safe a million times at different committees and at board. Actually seeing it and seeing a member of the team pick this up and say, this device is really helpful. And my manager made sure I understood how to use it and made it normalized for us all to use it. So we just use it as a matter of course. And that was really interesting to me because we can promote it all we like, but when the management has actually got in there and shown a team that it works, why they need to use it and how it works, and they feel confident using it, I think that makes all the difference. So again, this is a sort of quiet team that is a strong team and we don't necessarily hear much about, but I came away very happy after this visit. And again, other colleagues may want to add something to that.
Thank you. I think all accepted. Do you have another report or not?
I don't think so.
No, Maniza, I've got you down as the next one on the list.
Sure. I've got three. I'll take them as read. All three, I've now done a few board visits, so I think there are kind of a few themes that you start to see across. The second one, which was the one at Greenwich West, was probably the most sort of insightful or interesting. So just kind of as an observation, I've done visits to other services in the building, and there's a lot of unhappiness there. I think about the kind of general setup, about parking, about safety. So that theme cuts across services, and that's highlighted. I did think we've previously discussed the purpose of board visits there, and that visit did really cause me to reflect on that, because some of the issues that were raised, I mean, these are really thorny issues for which there may not be an answer, right? We've been trying and there just may not be an answer. And I think sometimes, or one that we can easily give. And I think sometimes that board visit, that sort of, you raise this problem with high expectations and there's a lot of disappointment. So I think that was a kind of theme. There was certainly, people said it quite explicitly. We've had people come here, talk to us, nothing happens. And I think there's that piece of, what people are looking to get out of the visit, because certainly some of the issues there isn't really an easy answer that I think is within our gift to give. But the sort of setup with the board visit is it's a bit of a cycle of disappointment, I think. So I just kind of share that observation there, and I think I've seen that in other places as well, when there are things that can be done through more regular management channels. Sometimes they kind of get raised as a complaint. Here, just
haven't been resolved, and we're not necessarily going to be able to resolve them either.
There's something there about us managing the expectations as well. When we go in, we don't have a magic wand that we can cure anything. Yeah.
That we can't. You know, it may be the purpose of the board visit there is to be an outlet for that frustration, which, you know, may have its own value, but it is a lot. It is sort of a discussion without an answer. So I just kind of share that observation. The other two, you know, visits were more, I guess, straightforward, for want of a better word, and you know, to Bromley West and to the old age memory service. I did both of those visits with IFE. I'll also just observe again, you know, it's a very different dynamic if you do a visit with IFE versus without, which I think we might also reflect on in the way we as NEDs understand the service. I mean, it's very understandable for the team. If you have IFE there, this is a chance to showcase, you know, what they've accomplished, and that's very much what people are doing. You know, with sort of versus where it's not. So I think just to throw that out there to other NEDs, you know, the dynamic is inevitably going to be different, and I feel like I get different things from visits depending on who's there. So that's just another observation.
Thank you, Steve. Site round. I think that's the next one.
Two things from my visit to Greenwich. There was certainly a security concern. Rachel and I have discussed that. It has been done well. Rachel will say that's the exact design. That's it. It dealt with basically. The other thing I just wanted to mention was unusually and it's very convenient. Being here, the knowledge and confidence in the freedom to speak up was low. Sorry. On the freedom to speak up, unusually the awareness of the program and the confidence in the program was very low. I've never actually experienced that before. I always get a high level of we know all about it, and we're confident because it's an independent system. So I think it was a bit of a one-off. And the good news is, because they said that, we pointed them in the right direction, and I'm sure as soon as we left, they would have checked up exactly how they access the system and how it works. So they were the only two things to report: the screen being dealt with and freedom to speak up being dealt with.
Thank you. It might be up and running. It's good to have you here for that one. Thank you. Jo.
Yes, we did catch up on, I think, some visits here, but some 3 forensic directorate visits. So the first one was to Danson and Birchwood. We did visit Crofton. They were dealing with an incident at the time, a gentleman in seclusion. We saw that they were managing it really well, but we couldn't really talk to any staff. There was quite a few of them involved in that. The Birchwood visit was quite interesting because one of the patients, for about the first 10 minutes, pretended he was the doctor. So that was quite good. He gave us a really good summary of the approach to healthcare on the unit. Could have been. It was great, actually. Said all the right things, so that's good. But yeah, a really good visit. You know, I think we saw some of the issues that were reflected in the culture report. You know, some very close working teams who the idea of people rotating across teams was not something that really appealed to them, because they really felt they wanted to come together. So I think that shows the complexity of some of those issues. On Birchwood, they were beginning to prepare for a patient they knew was arriving from prison. On a subsequent visit, we found out that really hadn't worked out very well at all. It was someone who really was not suitable at all to the ward environment, and they were, I don't know if he's Ian, whether he's now returned to prison, but it was quite difficult. Other than that, I'll take the report as read. The next visit was to the Liaison and Diversion Criminal Justice team. Again, we're going to do a revisit because I think we were a bit ambitious in terms of what we're going to get round. So we visited Woolwich Court and Bromley Magistrates Court. We are going to go to the police station, another visit, and we're just looking to arrange that. The individuals in this team are so highly skilled because they have to have great knowledge. They are called upon to, at fairly short notice, appear in court, do assessments, talk to the judge, liaise with a whole range of services. We were really quite knocked away, actually, with the ability of the people. I think it says in the report, they have had some recruitments that haven't worked. I'm not surprised because people are largely working on their own. They rotate them across sites, which I think is good. And I think we felt there was a really good team spirit, despite the fact they were working largely remotely. And that's quite difficult to achieve. But really interesting work. I think for the right person, a really great job. For the wrong person, it'd be horrendous. So that was really good. And the last one was Heath. I can't find it now. Is it before? Oh, thank you, Abby. So recently went to Heath. It was an interesting visit. I think previously they've had very long stayers in there and really very few discharges, but they've now got discharges coming up, which I think is really positive. And I think the team are quite excited about that, even though that of course means they then get new patients in and that is takes a while to work through on that. They have had, not unrelated to some of the things we've discussed already, some changes in the team, and they were very positive about those changes. There's a business case going through, I think Ian refers to it in his report, in terms of strengthening the team, because when that's going to the SLP, and they know what they want to achieve from that, which is really good. But I think the example at the bottom of page 86, there's actually a typo. We talk about the weekly you should be living on Heath meeting, not living on health meeting. And what they said was, for us now, that is a really positive meeting. It's where the staff meet with the people on the ward and discuss the week and what's good, what's not, and what they're going to do. So previously, they had to have a meeting after that meeting to kind of debrief from it. And now it was a much more open, transparent meeting. So it felt like really that they were moving in the right direction. We got to talk to a couple of the people on the ward as well, and they were generally very positive. You could see we got some interesting comments about gym equipment and the pool table, which Jane has followed through. But it was quite good to actually have time to spend time with the patients there.
Thank you, Jo. The liaison diversion service. My one question came out in my report from you was whether they felt sufficiently I couldn't quite work out from the report whether they felt sufficiently connected to the rest of Oxleas when making referrals or not.
I think so. They work with a lot of different agencies.
Yeah.
And whilst I think working with Oxleas, bits of Oxleas sometimes feels easier than working with outside agencies, that's not always the case. And therefore having cleaner referral lines and perhaps a wider understanding would be better. I don't think that's desperately different to what we see elsewhere in Oxleas, actually, in terms of referrals across services. You'll see there's a particular action that Jane is following up regarding when they need a bed, the consequence of them not having a bed is someone's kept in custody. Yeah. And for them to perhaps be a deeper understanding in a world where we know we haven't got a whole load of beds of that issue. So Jane, I know you're following that up. I think referrals across services across Oxleas is an area where I think there probably is still more to do, and they might find it easier. But really impressive individuals. We met a new member of staff who'd been, I'm trying to think how long she'd been there. The girl at Bromley, not long, 3 months or so, quite young, phenomenal, absolutely phenomenal.
Good. I think that's covered all the visits, has it? I think so. Good. Okay. I'm going to, so that we don't get rushed on the business, I'm going to jump ahead and cover off, if that's okay. Ask Steve to present his two committees, which is audit and risk assurance. He's also going to do the partnerships committee in common reports. It's items 40, well, papers 14 and 15, items 16 and 17. Steve.
I'll get the hang of this soon. Thank you, Andrew. I'll do partnership committee first. It was a bit of a holding meeting, is the best way I would describe it, because there weren't any major decisions, just updates, particularly around complex care, which is being slightly remodelled, but there was an assurance that there was no financial risk involved to any of the partners. There is a portfolio board meeting, which is fundamentally the executive, which is taking place next week, and there's also a big face-to-face conference which is taking place on the 17th of July, at which there will be some significant discussions and meetings. So the long and the short of it is, at our September board meeting there will be much more to report, quite frankly. But as you know, as we all know, the SLP over time has been pretty good at remodelling programs, actually, and quite successfully at making them better for service users and financially. If there's any questions, by the way, I'm happy to take them. Equally, I'm happy to keep going. The audit committee, 5 points to note, which sounds a lot, but they'll all be pretty quick. First of all, thank you to Rachel and Nina for turning up to present the people committee risks. And we also had internal audit report and e-rostering, and as Rachel and Nina will know, a robust discussion on that, I think would be fair, and long discussion would be fair to say. It did fall in the amber red category, but the internal audit work on 4 groupings. So if there was 5, as they said, it would have fell in the middle. It just fell the wrong side of that. But lots of mitigations and actions have taken place. And I personally, and I think Nina would be the same, and Rachel would be the same, am very happy with where we are. Nina?
I think we're happy with where we are. I think there's some lessons learned, both in terms of how we, both in terms of our understanding of internal audit and how we were able to engage with a process that KPMG were running in a particular way, and therefore some learnings for them that we were quite robust in feeding back as well. So we accept and will absolutely deal with the findings, but I think the broader lessons learned go to have been valuable on both sides.
Yeah, thank you for that. And I think they took, as you say, they did take note of what was said. Data security was also an item that was reviewed, but as Alison and I have discussed, we are, in, dare I say, Alison, a reasonable place compared to others, but definitely never one to relax, because no matter what we do, something could happen. Thanks to Sally and Rachel for the great work done on the annual report and accounts, because it is a huge amount of work. I
think people are trying to skip responsibility for their jobs.
Yeah,
here, I think.
And Sue, were you saying? Yes, and indeed, Sue. It's all completed on time. They were very good productions, and I can assure you, not everyone in the NHS works in the timescales as efficiently as we do. But the 5th one I want to finish off is the internal audit review for the year. I think things work so well in Oxleas that we kind of take them for granted. And the internal audit review was that it gave us a significant assurance with minor opportunities. There are no actions or recommendations outstanding. Pretty much every recommendation is completed on time. For us to get an extension to an action is really rare. And again, I can tell you with 100% certainty, there will not be many organisations in the NHS in that position. So as I say, I want to stress, because I think sometimes we get so used to how well our executive work, and in fact, I want to say it again, they do a great job.
Thank you, and I think we hear that, but we also thank the audit committee, because actually that's a really important part of that thing. You need the audit committee as well to make sure that all happens. So thanks to the hard work, because the audit committee is one of the harder works. Okay, thank you for that. Yes, understood. Okay, so we're now going to go backwards to item 11. Simon Patrick, welcome. So Freedom Speak Up Guardian, we have your report. Please bring out any highlights or anything you wish to say.
Thank you. Do you talk that side or that way? Does it matter? Can you hear me anyway? Yes. So thank you everybody for inviting me. Nice to see you all. Even though this is my third year as your Freedom Speak Up Guardian, this is my first time addressing the board in person, and I can confirm it is terrifying, but I'll be fine. Not remotely intimidating, I'll be fine. So yeah, my plan this morning is, you've all, I assume, hopefully read the report. So I'm going to go through some of the executive summary elements and expand on those for you to give you a little bit more information. So this report is an outline of the Guardian from the 1st of April 2023 to 31st of March 2024, and provides an overview of the activities and themes that were raised to the Guardian service in this time. I know that members of this board in the past have requested that I do some comparative data in this particular. I'm not looking at anyone in particular. Unfortunately, for benchmarking purposes, I had exactly the same problem I had last year, in that the National Guardian's Office and even the Guardian Service themselves haven't produced their annual national comparative data yet. So I apologise that that's not contained within this particular report. However, it will be out by the time I need to do the 6 monthly report, which is due in October, November. So I should make sure that the board report for that period has some more comparative data so you can benchmark yourself against other trusts, which I know is also very important. So, in summary, there were 52 new concerns raised to the Guardian Service this year. That is a very small drop on last year. There were 58 concerns raised last year. Decreases shouldn't necessarily be seen negatively. There's many contributing factors as to why there may be a slight dip. Also, one of the elements can be that staff are beginning to feel a lot more comfortable speaking up and then speaking up independently themselves. I have seen that this year, and I will touch on that a little bit later for you to explain what that means. From a theme point of view for concerns, the three main largest themes this year were, once again, management issues, which accounted for 23 concerns, systems and processes, which were 19, and behavioural and relationships, that were 5. There was no red patient safety or patient quality concerns raised this year. I'm going to break down a little bit of what those themes mean and what kind of things were raised. And please do bear in mind, these are not my words. These are the words of staff that have raised these concerns. So the kind of things and the recurring themes that came through were such elements as sort of managers close to input from team members and feeling that creating negative cultures in those particular areas. There was a few elements that came through with a lack of understanding from managers regarding neurodivergent staff members and how to communicate and how to deal with neurodivergent staff members a little bit more. There's a perception that there's a limited knowledge of the trust's more supportive HR policies around such things as menopause, etc. And people feel that the managers are not aware of those. Unapproachable and unsupported managers, lack of empathy, poor communication, inappropriate, unnecessarily harsh, lack of compassion. These are not uncommon, and they're not uniquely Oxleas either. I can assure you from my colleagues across all the other trusts in the Guardian Service, we see that across the board. So it isn't uniquely an Oxleas element. Under systems and processes, which is the second highest theme this year, with over 36% of concerns came through. It was a high one again last year, but that was all down to the elements of formal grievances, which I raised in last year. That has dropped dramatically this year, because I know that Rachel and the department have done a lot of work on changing that. So it's come, although it's still the second highest theme within the report, it doesn't come under that formal grievance element. So this year a lot of it was staff seeking additional help and support. Still during grievances or between any of those elements where they've come to that independent support from the Guardian Service. Other things that came through in this theme were deviation from agreed trust policies and procedures was something that came through a few times. Unfair recruitment practices was raised a couple of times. Feeling unsupported by managers during adjustment implementations. And one thing that came through quite a lot under systems and process this year was trust policies not being consistently applied across team members, leading members to feel unfair and division. So they're the kind of things that came through under the elements of systems and process. So we had quite a change in the job groups this year. The 4 job groups that raised the most concerns were nursing and midwifery, which accounted for 32%, additional professional, scientific and technical, which was 23, allied health professionals 17, and then followed by admin clerical 13.4. What was interesting was that the most significant increase was in nursing this year, And the most significant drop was in admin and clerical, which in fact was the number one job group last year. When it comes to changes in job group tendencies, I tend to find that they can become a self-fulfilling prophecy rather than indicative of a fundamental problem. If there's more nurses raising concerns and they're getting a positive outcome and they're engaging with the process, they tell their friends, they tell their other colleagues. So you do get these spikes in job groups, and as I said, it becomes a self-fulfilling prophecy because more and looking at the elements that I've received and the concerns, even though that's the number one group, there's definitely nothing in there that was systemic within nursing that was a particular concern. So from the directorate's point of view, the three directorates had the most concerns last year were forensic and offender healthcare services at 30%, adult community mental health at 23%, and that's followed by children and young people at 21%. One change that I have made this year, which was a request from the Trust, is that for the new recording data, we've actually divided forensics and offender healthcare services, although they are under one directorate within the Trust, to give you as a Trust a clearer understanding of what's going on within the different elements. I've now divided that out. So there will be separate concerns that come under forensics or separate concerns that come under offender healthcare, which I hope will give you a clear understanding of what may be going on in that particular area. Another element was that this was the first year of the reporting period where we'd updated the why people use the Guardian service, because I know this is one that always causes great discussion in this chamber when we've discussed it in the past, when it's coming up as sort of the old ones which were, they've sought help and have not been listened to, or they feel the Trust won't listen to them. And so we added the extra additional element at this time of seeking that independent, impartial support, being an independent guardian, being outside of the Trust. Not very surprisingly, or not to me anyway, but 67% of the staff who raised concerns this year cited that they came to us because of our independent, impartial support. So I'm pleased we've added that to it because it's shown much more, gives you a clear understanding of why people come to us. And I think that's been reflected in the notice of the staff willing to raise concerns themselves. But they come to me for that impartial support. I've seen lots more staff coming saying they want to raise the concern. They're happy to go and speak to their manager direct, but they feel they need that little bit of independent support. And so I've seen more and more people coming to me for that, which is why I mentioned in the beginning about that drop in numbers, because a lot of people I think are beginning to speak up themselves. And obviously if they do come to me in that respect of wanting that support, but then also knowing that if it doesn't go very well, they can then come back to me again. So I've seen quite a lot of that this year. The same applies to Guardian facilitated meetings that have also significantly increased this year. But for me, that still shows a willingness to address the concerns that staff have and just wanting that little bit of extra independent support in those meetings to be able to address it. I will mention, and I did mention it in the report, the last year's NHS staff survey results relating to freedom to speak up, because Oxley did buck the national trend. All four of your elements went up. I think it's important to acknowledge that. I think it's important to acknowledge it regarding that Oxleas are improved on all of those four questions, something that, as I said, hasn't been echoed nationally. And I think that is making a difference. But I think that's a combination of the work that Oxleas are doing, and I know they're doing a lot, and my embedding myself in the Trust in the last 3 years. I think that's also added to that. I'll end by just outlining a couple of the recommendations that I've made this year, and then I'll answer your questions, which hopefully you won't have too many because I can't hear at the moment. So yeah, a lot of the recommendations I made, not very surprisingly, come under the element of managers and manager training. And I know there's an awful lot of work already going on in the Trust relating to that. But there were a few elements that came up this year that were a little bit unusual. There still continues to be a lack of understanding and in some cases fear from managers of the Freedom to Speak Up Guardian. On two elements. One, if I call a manager, have a conversation with them, some of them panic. They go into instant panic mode and they're like, oh my God, the Guardian's called. Well, what have I done? Well, I can't talk to you. I need to speak to my HRBP. I'm like, whoa, relax, calm down. But that also feeds into that element of not just the fear, but there's still a slight lack of understanding from managers as what the Freedom to Speak Up does and what we're part of. Because We're not there to, we're there to break down those barriers. We're there to support. If I'm ringing a manager because a staff member's raises concern, I'm there to help both people. I'm there to help and support them. But there has been quite a significant increase in staff with coming to us because managers have said, oh, go and speak to the Guardian service. And that shows a fundamental lack of understanding. They've got two members of staff who say maybe in conflict, and their response to deal with it is go and raise it with the Guardian service. So that's fundamentally not understanding what we do, because our job is to get their voices heard by the right people who can action change. And I'm just going to end up going back to the manager and saying, so staff members have raised this concern with me. So I think there's some work to be done there within the trust in relation to doing that. Also, I've had a very good, successful year this year, visiting lots of teams around the trust. But the element of getting that support from senior management within the trust is so powerful and so important. I said in my report that I'd like to have a sort of regular communication from the lovely IFI and people really pushing that agenda for us and getting us out there. A perfect example of this, and I'm perfectly happy to raise this, is Rachel Matheson from ACPH. Now, they have taken the pardon my friend, the bull by the horns this year and really been actively pushing the Guardian service to all of their managers, to all of their team leaders. And it's led to the last 3 months, me literally seeing dozens and dozens and dozens of teams I didn't even exist, and hundreds of staff. And it's been incredibly helpful. I think the gentleman over there, did he mention the Greenwich Community Mental Health Hub and about Freedom to Speak Up? That's funny because I've been invited to the Plumstead Centre to talk to district nurses and stuff for ACPH. And I just saw that big sign on the wall, Greenwich Community Mental Health. And I thought, I've never even heard of Greenwich Community Mental Health. So I popped in. But this is one of the problems I have from Oxleas. If I don't have that help and support and information from senior managers as to where these places are, I don't know to go to them. But I did actually pop in there and talk to the manager, and we've actually set up a whole training with all of their staff next month. So that's good. So hopefully that's all made sense to you. I hope the report was a good one for you this year. And this is where you will wave your hands frantically and ask me really complex questions I won't be able to answer. So please go ahead.
Well, we'll ask some questions, but hopefully not. Neil.
Such a helpful report, and from my position, in the senior managers, it makes me think just how much investment we need to do with local managers. Sounds like there's quite a lot of between team members and their local manager. I think the issue of the local manager telling people to go to the Guardian service, we had a very similar issue with clinicians telling people to go to the PALS, the liaison service, which is again the same misunderstanding, but perhaps something about an overwhelm that they feel that they want to outsource difficult conversations sometimes. So that's very helpful for us to see and target some thinking about.
Yeah, no, absolutely. And I don't mean to make it sound accusatory in any way, because it isn't. When I have then gone to some of those managers, they said they weren't quite sure what they were going to do about it themselves. And I'm happy to have those conversations with them and see how I can support them as well. But I think there is some work, as you say, to be done to just have that understanding a bit clearer within the management structure.
So it might be about advice, acute advice to managers in difficult circumstances.
Absolutely so.
And just to say, following up from the executive team looking at this report, we have invited Simon to come and do the sort of presentation to our September meeting about the annual report and have that conversation direct with a bigger group of managers so that we can try and get that going.
That would be good. Abby, and then Susan.
Thank you very much for the report, Simon. And I suppose because I did the Edenfield report for the board last year, I'm usually quite loud. You hear? Sorry. Yeah, I was looking at the themes. And it's the same as it was last year. One thing that had concerned me previously, and I'm not sure whether it should, is that people don't come with clinical concerns. And that may be a good thing because it means their clinical concerns are getting addressed elsewhere rather than through the Guardian service. And in terms of other trusts do people bring clinical concerns? How do we benchmark?
I'm so used to being loud myself, I don't usually use a microphone. Yeah, of course they do, but you can't, for example, say I'm the backup guardian for Barts. You can't compare Barts to Oxleas. It's a completely different, massively acute trust with huge hospitals, and almost 90% of their concerns are obviously going to be clinical. I do find within Oxleas, I'll get the occasional clinical concern, but the majority don't come from the clinical side. I don't know if that's an issue within Oxleas or not. I don't know.
Yeah, I just wonder if actually there's more we can be doing to make sure that our clinical leaders are highlighting the Guardian service as a route for raising those sorts of issues, because I wonder if there's something about our messaging perhaps which does seem to focus more on the sorts of issues that you generally get, rather than perhaps highlighting it as a clinical option too. So I was just reflecting as Abby was asking the question, it tends to be brilliant people like Rachel Matheson talking about it, but does it have a state, could we be raising its profile at the MAC or at the Nursing Council, etc.? Could we be doing more in that space? And we might see that we tap some unmet need.
It's noticeable there are no medics using the Guardian service this year, which is notable, I guess.
Yeah, no, that is a concern from my side as well. But what I find quite interesting, because I've suddenly had this massive influx of staff that I haven't spoken to for years in ACPH, and it still surprises me when my first question is always, do you all know what a Freedom Speak Up Guardian is? And then I'm normally looking at a blank, complete one, even though there's a poster behind me with my face on it saying speak up to your Guardian, but that's another story. But there's still this perception that it's whistleblowing. There's still this perception that the Guardian service is whistleblowing all the way back to the Francis report. And yes, that's where it started, but it's more than that now. It's developed past that now. We are there to still deal with those difficult concerns when they come through, but also to support staff to find those resolutions. So I'm wondering if, like Rachel said, maybe there's an element within clinical that there's just not a clearer perception of what we can help and what we can help with.
So on this issue, Ian, and then we will turn to Suzanne.
Yeah, great report, Simon. Just linking it to the kind of forensic culture review. So I was surprised and to an extent pleased that there is quite a big uptake in forensic services. But what's interesting, and it speaks to that last point, when we started having the conversations with teams, there's still an element in some quarters that they don't know about it. So there's I think we need to take the Rachel Matheson challenge and kind of put it out there. But to the point you were just making, I was just trying to find the email for the exact words because it did strike me when I read it. It was something like people describing what their perception of the Guardian service is something that is quite formal, and what they're looking for is something like citizens' advice, and they feel that isn't something that they can come to you for. So again, there's maybe something about how we modify people's sense of yeah.
I wanted to pick up a point in the report which partly connects to the clinical piece. I have to say, I think every single Guardian report that we've had since I've been a NED has recognised that we're not picking up clinical concerns. And I don't think this is unique to Oxleas. I think for one reason or another, right across the health service, people see this as an additional way to raise semi-grievances, if you like. It's something to do before you have to go down that quite distressing avenue of raising some form of grievance, or more formal way of complaining about your boss. And I think we really need to think about this, because what struck me in your report was, under system and process, reading that people were raising with you about deviations from agreed trust policies and procedures. Now, if I think back to what we see when we do patient safety investigations, what do we see time and time again? It's deviation from agreed trust policies and procedures. And yet, those are not the sorts of deviations in clinical work that people are raising to you. And I think my challenge to colleagues, I think that you're doing a really good job as a guardian, as perceived by our staff, about what you're there for. And I think it serves an important purpose. But if we really want to understand what we're not hearing about in terms of clinical concerns, I think we need to find a different way of doing it, because, repeatedly we're not hearing those things through the Guardian. So I don't know what the answer is, but to some extent I think it reflects Neil's point. What do people are people going to use the Guardian service for? And if we want it to be about raising clinical concerns, then we need to come at this a bit differently, because that's not what we're getting.
Joe, then Jane, then I'll let you respond. Simon.
I think this is I think the crux of the matter, and I think in Oxleas there's lots of different ways of raising concerns, and I wonder if we ought to kind of settle that out. I'm on an audit committee elsewhere in our organisation, and we just received the annual whistleblowing report, which tells you nothing. They've had no whistleblowing concerns. I'm like, well, I've got no, how many complaints, exit interviews, all sorts of stuff in there. So it's difficult to look in the absence of that overall context. We have a 6-monthly meeting with Simon, with Rachel, with Iffy. Vicky comes to that because we get really good insight from Vicky about her visits, what the CQC are saying, and we've also just introduced staff side to that as well. And I think the last meeting we had, hopefully it was quite useful for you, Simon, in terms of, we're getting raised concerns here, raised concerns there. Also up through your medical route as well, and I meet with Abby, with Nina and Rachel as well, and we discuss sort of bubbling under issues as well. But I wonder if we ought to, almost on one sheet of paper, set out all the different ways we have of raising concerns and actually challenge ourselves to say, are there some gaps here? Can we do better in some of these areas? I think that might be quite useful. But I like the idea of there isn't just one way to do it. There's lots of different ways. The other point I was just going to raise in relation to managers saying, ooh, that's a bit tricky, talk to Guardian service, is how much coaching we give managers. I know we're doing formal education, but when I was a manager in my sort of exec job, when I had one-to-ones with people who reported to me, most of the one-to-one was about managerial issues. I get the sense that in some areas that's not quite the case here. It's more about performance issues. Also important, but someone once said to me, you mustn't forget that being a manager is as much part of your job as the content bit. And I think there are areas where management is just an inconvenience, and we need to help people more.
Jane, then Nina. Dave.
I think I want to add to the fact that there are different routes to the Guardian service. For nurses, we are seeing really good success with the PNAs, the professional nurse advocates. We've got 40 at least, and we've invested now in training another 30. And what nurses say they like about it is it's nurses supporting other nurses, and that's where they have discussions around things that worry them, and that's where some of the clinical concerns come up, because they want to test their assumptions. They don't want to be the only one to spot something and call it out sometimes. Some of these people are very junior. So I think it would be really helpful if we laid out everything and gave people that variety of options to utilise. But what would be really interesting is trying to get a picture of where different options work well. And I think it's that outcome that people are looking for in terms of how they choose where to go and what to do. But from our experiences, people who've used your services have found it really helpful. So I want to say thank you.
Nina. Yeah, and then Nita.
So 2 points. The first is I think Joe summarised it really well in terms of needing to have a kind of universe or a map of all the various routes that we have for colleagues. But I just wanted to come back in my second point on the journey that we've been on to get to where we are today. So I remember very clearly that I think Rachel and I were completely new to respective roles at the point at which we made the decision for Oxleas to go externally for the Freedom to Speak Out Guardian. And there are light years between the quality of analysis that we get as a result of the relationship that you've built. And I just wanted to say thank you, because I know you invest an enormous amount of time and energy. And for me, it was really touching to see and read the comments on the last page of your report. So you're clearly having a massive and very important impact, and genuinely grateful.
Last point, then.
Thank you.
It's a question because I'm not sure I really understand the issue we're discussing, and I don't know whether this is for Abby or for Simon, but when we talk about people raising clinical concerns with the Guardian service, what does that look like? Is that I'm concerned, I don't know what to do about X patient, or I'm concerned that someone is not providing care? What is that question, and what do we expect the Guardian service to do?
It could be broader than that, but it's usually the latter. And I suppose why I brought it up was because on the back of both Edenfield and the Lucy Lepp case, boards were asked to make sure that they had an appropriate route and routes to enable clinicians or even non-clinicians to express concern in terms of the care that people are receiving. So you could do that via the Guardian service as well.
Simon, quick final response.
Thank you very much for your very kind comments. I do work very hard in this trust, and I do care a lot about this trust, and I have worked very hard over the last 3 years to sort of establish those relationships so that I can do the job excellently, but from an external point of view. One quick thing that just popped into my mind relating, I'm very, very sorry I didn't catch your name at the end, but you were saying about how we differentiate and how we show how the services work. I'm wondering if I should write up a number of case studies that could possibly be that couldn't identify anybody, that could go in the Ox and just show what the process, how it worked and how it came out. That might be a way of giving people a clearer understanding of what we do and not having that automatic assumption. So, if you think that's a good idea, it's something I'll certainly look into.
Simon, you're getting lots of nods around the table, so I think something like that would be helpful. So thank you very much. And I think, from here you get a sense of how valued this service is. And so thank you for that. I think there's a piece of work that we've talked about doing, and we've got to map somehow all of these routes that we have to get concerns and check that we're covering everything. And I also think we should take it a step further and see how that's feeding up to the board, so that check all of those routes are going up to the board, so that we're seeing all of the picture. So the PCNs are clearly doing a great job. Do we hear that up at the board? Should we, or at the relevant level? How does that feed up? And so that we get that assurance, because actually, if the clinical stuff's been dealt with elsewhere, we don't mind. It doesn't need to be dealt with the Guardian, as long as it's being escalated in the right level. There should be a degree of redundancy. We've talked about that, but there shouldn't necessarily, not everybody needs to do everything. So thank you very much indeed.
Good one.
Thank you. You may go if you wish, or you can stay for sandwiches in hopefully 10 minutes. So we'll try, and because we spent quite a long time on that, quite rightly, I'm pleased we have. But I think just to warn people that you are the only people standing between yourselves and lunch. Quality Committee, Suzanne.
Sorry, I'm having the same problem as you with too many items on the on my iPad to find them. So, Quality Committee. I wanted to speak really to the alerts, and the first one around the COMAD activity. I've already touched on earlier that the committee received a really useful report on the development in those services. And what we wanted to just bring to the board's attention here is the rethinking around the current model of provision to make sure that, particularly in relation to forensic services, we've got enough people and the right approach. The second alert was around the resuscitation equipment audit, and I think it'd be fair to say that the committee was disappointed to see this, and a little worried, because it has been a matter of discussion before, and we have raised before that the Resuscitation Council recommends having a yearly audit and training cycle, and we're still working on a 2-yearly one. My understanding is that part of the issue here is with capacity in learning and development to be able to provide a yearly ILS updates. But this is being pursued, and the committee made clear that we would like that work to be completed as a matter of urgency. The other alert was around the risk, the harm to triangle of care due to poor communication, which we've talked a little bit about today, because this was the reformulated risk that the service user and carer shadow committee brought to us. I'd like to take the opportunity again to say that I think that this was a really impressive reframing of a risk. I think it has real implications right across the trust, because this impacts all services, and isn't something that can be resolved by patient experience leads, for example. It needs to be resolved in every instance of clinical interaction, and indeed probably non-clinical interaction. So we recognise that this is a potentially transformative risk, and it's one that we'll be looking at closely. The discussion with the subcommittee, which we had before we met as a quality committee, identified that what we really needed was a very clear plan of mitigations, but that we didn't yet have it. So what we have in the risk is a plan for a plan, and the committee has asked for us for that to come back to us in September. And the last alert that I wanted to touch on, Vicky told me that I shouldn't put this as an alert or a positive alert, because she said to me, you're just going to be tempting fate, exactly. But we did think, after the presentation from the Offender Healthcare Directorate, that whilst there are barriers and pitfalls, overall there has been, I think, real improvement and progress around some of the problem sites, and particularly in the southwest. Across the directorate, I think one of the things which was impressive in their presentation was that they're building a quality improvement culture in the directorate, and people who have been around the board table will remember that at one point we were talking a little bit about whether offender healthcare saw themselves as a bit of an empire of their own, and I think that one of the things that is becoming clear is that they're not a separate empire in Oxleas, that they're beginning to practice the cultural principles which we want to see in all of our services. And looking for, one of the things that was reported to us was a QI project at HMP Sutton Park, which was about reducing do not attends. That was a fabulous project. It's saved a lot of wasted time, a lot of money, and has been very successful and has been sustained. And I would just like to take the opportunity to mention that I was listening to the radio the other day, and East Sutton Park had a presentation at the Chelsea Flower Show, which is about the work that has been introduced there for prisoners to engage in horticultural matters, and it was a really moving, I can see Jane saw it as well, it was a very moving little excerpt, and it says a lot about what it is we're able to accomplish in prisons when we're doing it well, and I think that's the aspiration that we really have for all of our prisons.
Thank you. Jo.
I just had one question about polypharmacy. So I thought the results of this Bromley polypharmacy audit. So firstly, 37% of patients had more than 10 medicines, and then 71% of those we proposed presumably changes to their medicine regime. And I know it says discussions include the need for continuous review of polypharmacy. It felt to me that those results, so effectively of all the people covered, 25% of the people across had interventions. Is there further improvement work going on to actually sort this or help this at source? I know we mentioned GPs in here, but I know also from the work in adult physical health on the frailty pathway that polypharmacy is probably the biggest. When we take those patients and review them, polypharmacy is one of the biggest issues there, and we can actually help people quite a lot. So I don't know.
The simple answer to that is yes. It's multifaceted. So at the Medicines Management Committee, we have the chief pharmacist from the ICS, Greenwich, Bexley and Bromley. And this was from the Bromley one, so Bromley Moss Service. So Issy, who's the chief pharmacist there, will be doing some work with primary care, but also in terms of the practices that work within there, we'll be doing some work with them, and it's a constant problem. And if you don't have regular primary care staff or GPs, things get added on without reviewing. And you can ask a patient, why was this prescribed, or ask their family, and they don't know. So people are then worried about discontinuing medication, but it is the single most highest risk factor for people is polypharmacy. So that's why the Bromley Moss Service was even commissioned in the first place.
Thank you. Any more questions for quality? Thank you. Jane, mortality report. They have a homing down to the centre of the table.
Sorry. This report's been reviewed at the Quality Committee. What we were particularly focused on was the 8th Leader Annual Report. There are some marginal gains, I think we could say we're coming out of the report, but still some stark inequalities still. And we noted the really positive work, just a flavour of it is in the report around what the Learning Disabilities Directorate are doing, particularly around physical health. And there's some really great initiatives over the past few years which have been embedded, and some new work starting as well, which we look forward to hearing more about.
And a slight shift in mortality, actually. So we're actually seeing a shift in outcomes.
Yes, we are seeing very slight. I think the 8th report showed a slight increase in the age, but still some ethnicity disparities were jumping out, and still much lower than the general population. So there's a lot more to do.
Good.
Just to add to that, with mortality, I still think, and I know the ICS is absolutely mired in finances, but I think this is a great subject for the ICS to take up. I think we are doing a lot of good work and often come up with sort of best practice recommendation or best practice notes from leader reviews in terms of our services. The issue, frankly, is largely elsewhere. And I know we had the Oliver McGowan training come out. I would love to know what the take of that training is across the ICS, because to be frank, everyone within learning disability here would have undergone the training. I'm sure we've all undergone the training. Yeah. I'd like to know what it is in acutes, because, in acutes and primary care are often the areas where it's kind of basic things, screening and annual health checks and things like that continue not to be done, and inappropriate decisions. So amongst everything else, I think this is almost an easy, I don't think you need to throw a whole load of money at it. I think it's awareness and actually just getting it on the agenda and moving forward.
Rachel.
Just to mention that I do have access to that data, so I can happily share that with you about what the take-ups are on Oliver McGowan across South East London, so I'll share that.
I do think closing inequalities is one of the best measures of quality you can have, actually, because yes, Ian.
Yeah, just to say, at the ICB executive yesterday, Andrew Bland started the meeting by reiterating the fact that they are he is expecting and full coverage in terms of this training, and a suggestion that take-up rates are being looked at. So I took that as commitment. Yeah.
Thank you. Good. Thank you. Business and infrastructure, Jo.
Thank you. So Ife obviously spoke about the ICS situation. In terms of finances, we are on track with our plan, which is good news. There's a little bit of an error in the paper. Where are we? It's, yes, on page 131, it talks about the business committee approved additional funding for the Heathview project. This is where soil investigations have shown that the further work is needed to complete with that, which meant it came within the business committee approval limit. It talks about the details to be provided in part 2. The eagle eye would have spotted there is no part 2. So that's inaccurate because it's within business committee approval, so it doesn't need to go anywhere else. Other than that, I was going to take the report as read.
Thanks. Any questions? I guess for me, there is that sense of the penalty at the system level for going over. How worried? How big is that in your sense?
Yeah, it's coming at us. I mean, I think it's, from my view, and obviously Azra's on leave, but it's this mechanism is much more transparent than I've seen something before. So, we're now into, because of our performance last year as a system, we're into paying back mode. As Ife referred earlier, how confident, I feel pretty confident that as a trust, based on what we know now, we should make our numbers this year. How confident do I feel as a trust that we're going to do it? Not really. We know that even within King's number, there's quite a challenge to get to their target, and that's before you think about the impact of strike, and particularly Synovus, which kind of knocked everything sideways. So it's both a worry, and to be honest, I think it's going to be such a large number that you can't really worry about it, because it's also affecting the capital as well. So we've had our capital trimmed back because of performance on revenue. And again, if that continues, then at some point something has to give. So it's both worrying and you can't really worry about it because you've got to focus on other things, really.
I think that's very good. I think that's very good advice. Obviously we fight at the ICS level for what we have to do, but actually we worry about our performance. That's looking good in terms of everything else. Thank you. And tomorrow's problems will be sufficient unto tomorrow. Thank you. Nina, the People's Committee, please.
Thank you. So in terms, there's a lot that we've covered on today's agenda that actually goes to People Committee business. So I will not go over that again, but to pull out things that we haven't covered. So every 6 months, we look at the biannual safe staffing report, and committee members will know that we've spent an enormous amount of time on this particular report over the last few years. The purpose of the report is to provide assurance that we have safe staffing levels. And it's done on the basis of a triangulated overview of our staffing against that maps actual staffing against recommended and budgeted establishments. And as a result of the focus that we have been able to give the area over the last few years, there's been some really good work done by Aisling and others in terms of understanding rostering practices, understanding everything that goes to. So it goes beyond just safe staffing, and I'm keen that we continue that, because in the report you'll see that there is just one area where the establishment needs to be reviewed, which means that the actual establishment and the budgeted establishment is less than what is recommended using the triangulation methodology. But there are a number of areas, and work is proceeding on that. There are a number of areas that we see where we consistently see that actual is above budget and budget is above recommended. So we're continuing to do work to understand what more needs to happen to address some of those themes. And we will continue to come back to that in the next year. In terms of additional assurance items, as we had trailed that we would do at the May board meeting, we did do a little bit of a deep dive in terms of the discussion that we had on fire risk to gain assurance that the fire risk assessments are in date. If I remember correctly, 2 will be due by the end of August. Rachel? By the end of July, okay, and we're going to make sure that those are up to date as well. And fire drills have been continuing on a satisfactory basis. You've obviously heard the report from Simon on freedom to speak up. You have also heard from an advisory perspective the decision that we took around the BAF risk rating for vacancies and recruitment pressures. And Steve covered the internal audit report on rostering. We did, as we always do when we receive the RES and the DES reports, we did a little bit of a deep dive into trying to understand the overrepresentation, the ongoing overrepresentation of BAME staff in disciplinaries. There is a journey in the right direction, but there is a lot of complexity that sits behind some of those numbers. And what is very pleasing is as a result of the Just Culture panels that have been introduced some time ago now, the number of disciplinaries overall has reduced dramatically to 18 compared to a number that was 3 times that just 3 years ago. We also had a really uplifting presentation on professional nurse advocates, and I would love to be able to get more of that stuff to come to board if we can, because it's a fantastic example of some of the innovation that we're doing in perhaps less conventional areas. Happy to take questions.
Thank you. And interesting, the professional nurse advocates keeps coming up in various places. It is something that maybe we do need to have, it would be helpful for us to have sight of, because we keep picking that up. Would that be possible, Jane, at some point? Thank you. Questions or comments for Nina? I think a lot of what you said, as you said, has been done elsewhere, but and getting that staffing right in all those levels and understanding that is a key piece of work, because it also ties into the productivity side of it, doesn't it, as well, which we need to do. Thank you. I wasn't unfortunately at the Council of Governors report except on celluloid, so Sally's agreed to cover that.
Thank you. The report brings a summary of what was discussed at the Council of Governors meeting, which was last Thursday. And particular highlights are that there was the NED nominations committee held that same day as well. And so they reported to the Council of Governors that they're getting the process started to recruit new non-executive directors to replace Steve and Joe, who will be leaving us sometime soon, and also for the reappointment process for Nina as well. So that will be taking place over the coming months. There was also notice that the voting for our elections has started. I think that started a couple of days ago, and that will take place through the coming weeks, so that we have new governors coming on board at the annual members meeting later this year. And also within the report, there's information about the governor activities that are taking place and the involvement that we have of trying to get out into the community. One aspect of that will be taking place tomorrow when we're involved in an event at Pakenham Cricket Club, where we hope to engage with local members of the community there. And there's an active programme of training and development for governors, and there's details of different visits that are taking place. And if non-exec directors would ever want to take part in those visits as well, you'd be very welcome. Thank you.
Yeah, questions for Sally?
Sorry, is less a question than a comment. I think one of the most interesting bits of the Governors' meeting was the presentation, which is described here as Oxleas in Bloom, that was led by Karen Janodi and Ahmed Solomon. The thing that was really striking about it was how central using our estate and recognising what we have. We're really lucky to have a fabulous estate that we can enhance both our staff and our service users' experience. And part of what they were presenting were the plans for the Memorial Hospital site, and they were asking for ideas from governors about what they most want to see there. I think that there's an important issue in here for our clinical staff also recognising what an important resource we have available to us, because it's great to have it there and it'd be lovely to have walks that people can do, but unless they are prescribed or encouraged or really used, the investment in that part of our estate is going to potentially go to waste. So again, I don't know whether this is something that the board might want to know more about, because I noticed that it's intrinsic to the new strategy in terms of our sustainability, and I think it's an important part of that because it brings together the environmental sustainability and the real healthcare benefits of engaging in nature.
Thank you. So I think there is something there. I think your last point about this is where in actual fact the environmental sustainability directly helps the people that we serve, rather than the indirect way that it does, obviously, and we should do it for that reason. So I think it would be good to know more about that one, and certainly I've been approached and I've been in contact with Rachel about people who are keen to use our estate in other ways that would potentially benefit either our current users or future users, or additional users. So I think there's something there. So we'll keep that in mind, I think, in the estate spot strategy, and hear something about that. Thank you. That ends the, if you like, the business part of the meeting in terms of reports and things. We've just got a few minutes left, and I guess, first of all, reviewing the meeting today. How was the meeting? I will kick off with two observations. First of all, I think I probably need to chair it a little tighter so that we get through the business a little faster, but I'd be happy to take comments on it. I'm also going to raise the only time it's ever exciting, and I'm not sure that that's true. I'm going to have ring mirrors added to my computer, so I know what's going on behind me some of the time. But any comments on today's meeting? What could we have done better to have got to where we got to? Or what did we do particularly well today that was helpful? I mean, the previous meeting, we started off with a more reflective period. We didn't particularly do that on this meeting. Is that something people, I don't think you build it exactly in like that, but it's something that people would value. I'm getting some nods. So build in something reflective at the beginning of the meeting to ground us, or somewhere in the meeting to ground us. I'm getting a yes from that. Any other thoughts about what we could do differently to make sure?
But when we've got speakers, I kind of feel like we should make sure they have a chair or they have a place where they are, because I kind of felt as though people were kind of hovering a little bit, and I want people to feel as though they have a space around the table. It's only tiny.
Yeah. I mean, it's interesting. Simon actually asked to sit quite close. He wanted me to translate for him if he couldn't hear. But I think actually that's a good point. We should make the speakers more welcome in that sense.
One of the things that struck me as I walked in was I really liked that row of chairs. It feels as if you're engaging with members of the public and others who are actually attending the meeting. So I hadn't seen it before, and I really like how it brings people into the room.
Yes, I think I've got to think about how I deal with that one because it's all behind me. But I think that's a good point. Thank you.
Can you remind everybody to vote today?
I think that's a non-political thing, so I think we can remind people to vote. That is always allowed. Sophie.
Yeah, just back to the point about reflection. I find at the end of these meetings, I find it quite difficult to reflect because there's been so much discussed and it only comes to me afterwards. So I really welcome a bit of time to almost do that before we start. Maybe think back to where we were before and reflect on where we want to go at the end.
Thank you. So I'm getting a sense that we do want to do some reflection at the beginning of the meeting going forward. So somebody else's. Yeah, let's go to ask.
Yeah, that would be great.
I have a microphone. Sorry, you got the big one. You got the lollipop.
All right, I'll try and do it justice. First of all, thank you for having me. It's been really useful from my perspective, and I will be taking away a lot for my own reflection from your interaction. I think it's really nice to have a space at the end of the meeting to think about what worked well, maybe what didn't. I think my observations are that some of the things I've observed in my own board at Elft and in other boards is it's really nice to have a rotating showcase. Some boards alternate with a sort of service user-led presentation or initiative, and then alternate that with a quality improvement project from a team where they come and they share what they're really proud of and what they've achieved. And it's something that the board can really engage with positively and get a real visceral sense of how things are occurring. And I don't know if that's something you do, but some places build that in as a sort of regular occurrence, and that can be really quite nice. And I guess the other thing that really struck me too was some of the NED visits and the structure that you have around that. And I think also taking, Moniza's feedback in particular around, depending on who's on the visit, can really influence that interaction with the team. And I know certainly from my perspective as a director and in an organization, when our visits occur, I don't even know about them until after, because they're designed to be as, I guess, impartial as possible. So NEDs are booked in on their own individually with a team manager, and then board members come in and do their separate visits. There's actually quite a lot of them. And then I get a sort of automatic feedback through this sort of template that the NED or the exec completes, which just sort of highlights to me in real time what the issues are that have been highlighted in a team, and allows me to then check in with the team and find out how they're feeling about that. And it feels very immediate. And obviously, just from my perspective, that's something that I think works relatively well, and I wanted to pass on. But again, really appreciate the opportunity to join you guys. And if I have any other reflections, I'll pass them on to Ian.
Thank you, Bailey. Thank you. It's always good to hear from other people. Any other reflections or thoughts at this moment, or lunch is calling? Forward agenda, we have a forward agenda laid out. I think we're picking up some items of business, and one of the things I think I need to do is sit down with Sally and propose some items of business for the development days. And we've logged some things from the last meeting, which we're putting in there. So I think we bring back to you perhaps at the next meeting a more formal one. But if anyone has anything they particularly want to put in, either now or email Sally and myself. And in the next, I think we're meeting next week, aren't we? So if we could do that, that would be good. Does anyone have any other item of business? Do our governors have anything they wish to say? Do you wish to say anything in particular? Or not in particular even? Well, thank you. And you're always welcome. Good. In that case, I will bring this meeting. Sorry, hello there. Hi. I'm happy to ask you a question. Could you take a microphone just so people can hear? And
thank you very much.
Yeah, I think it is on. Yes, it is
on now. Thank you very much. As I assumed it was okay as per your board thing. Quick question, which is kind of was touched on during the meeting. So I'm asking in the context, I'm a chair of a PPG, of GP practice, and we're on the boundary of Bromley and Lewisham. But I've also know other PPG colleagues who are in other boroughs, so it's a similar issue that operates potentially across the ICS footprint. If a patient is registered with, so in our instance, a Bromley GP practice, but they live in Lewisham, with regards to mental health, you've obviously got two trusts, one SLAM and yourselves operating in different boroughs. There seems to be some confusion around referrals as to which trust should take the patient, or that has been communicated to us. I'm assuming that's just a communications issue, and there is an agreed policy across the ICS and with SLAM as to what should happen. But I just think clarity would be helpful. Thank you.
Thank you. I think that's relevant. Others in this trust will have heard that as well. Ian.
Yeah, thank you for the question. Last year, at ICS level, in line with kind of the move across London for adult mental health, we moved to referrals based on residency.
So the question is, how do we communicate that? Whether that's actively adequately communicated.
I had a conversation with one of the mental health practitioners that now are embedded in general practice, and they were sort of getting bounced back in confusion as well. So I think that was helpful if general practice were made aware of it, so that medical sector then push back if they're challenged.
Good. So I think that's really helpful feedback in terms of communication. So we will work on it. Thank you.
Yeah. Thank you very much.
Thank you.